Ahmedabad, and Srinagar, and Kochi. Yes. I will not take your time. I will ask Sunil to get the ball rolling.
Thank you very much, sir. I think this is the best time to have a meeting on HCC. Now that there's been advancement in the diagnosis and management of HCC, especially the systemic therapy. And we all know that surveillance and prevention is very important for HCC. So just to get the ball rolling, before that, I invite Dr. Ashish to give us an overview of the format of this meeting, and then we start.
Thank you, Sunil, and thank you, Dr. Acharya, for those kind words. It's under your guidance that we did all the guidelines. The INASL had published the first HCC guidelines under chairmanship of Dr. Acharya in 2014, and we held the meeting at Puri, so we called it as Puri Consensus. Subsequently, the second edition of the HCC consensus was published in 2020. The meeting was held in 2019. And then third consensus meeting occurred last year, 2022. And the guidelines are about to be published within a couple of weeks. They'll be available, and all under the chairmanship of Dr. Acharya. Under his guidance, we collected and wrote all these guidelines. So the INASL decided to spread the message and do small meetings at multiple cities. So we decided on 6 cities. We completed the first HCC evening symposium at Kolkata, which was held on 20th May. Now, so this is the second one. Third, as mentioned, is in Bangalore, then Ahmedabad, Srinagar, and Kochi till November. So the format of this meeting is this is a small meeting with focused discussion on all aspects of HCC, including diagnosis, screening, surgical management, loco-regional therapy, systemic therapy, liver transplantation, and also a case-based discussion where we will discuss real-life cases. So it's we have tried to be as interactive as possible, and we have kept the lectures 15 minutes duration and the subsequent discussion about 10 minutes. And I encourage everyone to participate in the question answer session. And these meetings are also live streamed on live telecast on the YouTube channel, which will be available throughout. So I would not waste much time, and I would invite the first speaker and the chairpersons for the session. The first topic is etiology and risk factors of HCC, which the lecture will be delivered by Dr. Yogesh Chawla. And I would like to invite the chairpersons for this session, Dr. Arvind Sahni, Dr. Usha Datta, and I would invite Dr. Subrat Acharya to chair the first session. And Dr. Yogesh Chawla can come.
Well, I don't think Professor Yogesh Chawla needs any introduction to the audience in Chandigarh. The former director of PJMER, former head of the Department of Hepatology at PJMER, the former president of Indian National Association Study of Liver, and my dear friend. I will not take any more time. Get going, sir.
Thank you, Subrat. It's a great occasion. I had a chance to listen to the Calcutta meeting on HCC. It was simply wonderful. And I hope this also turns out to be very good. So I'm supposed to talk on the etiology and risk factors for HCC in India. We all are familiar with what are the risk factors now. But HCC basically is a leading cause of cancer deaths globally. And data from Global Burden Disease Study, which was published in 2015, showed that there was a 75% increase in the incidence of HCC from 1990 to 2015. And this was possibly 47% because of the changing population age and increase in population 35%. Predominantly, males are more affected, and 5-year survival initially was reported to be 18% because all these patients were detected late. The etiology differs in different countries, but overall, hepatitis B is the commonest, followed by alcohol, HCV, and 16% was others. But this data is of 2015, and I'm sure NAFLD has taken over. We would present our data from PGI as well. Unfortunately, in India, the HCC is not a reportable disease, and whatever registry is there by the ICMR, it is with the pathologists and it is urban based. So the data is very incomplete on HCC in the country, except for the tertiary centers, and it's variable, there's uncertain quality. But by and large, the crude incidence of HCC in India has been reported to be 2.8 cases per 1 lakh patient years, and crude mortality also is almost similar. But in 2014, Dr. Acharya had published that the incidence of HCC is rising over the last few decades, and it has been the experience of all of us. Unfortunately, despite surveillance strategies, these are patients who are diagnosed late. And only about 30% of patients get diagnosed early, and they are subjected to curative therapies. Now, this is one of the largest data from the country, which got published from PGI. Data collated from 2007 to 2015. There were 63% patients of virus-associated HCC, and the remaining were non-virus associated. Hepatitis B was 20% in that series, HCV was 17%, HBV and alcohol in combination 12.3, HCV and alcohol 14%. Alcoholic liver disease as responsible for HCC and NASH was almost similar, and others were a small group of patients. But I want you to see this. This is the changing trend of HCC over the years. During that time, we noticed that although HCV was stable, hepatitis B had come down, alcohol was also stable, but non-alcoholic fatty liver disease had increased as a cause of HCC. Again, in that huge series, about 86% of patients were cirrhotic, 14% non-cirrhotic, 27% of patients with HCC had an alpha-fetoprotein of less than 10, and they were all diagnosed radiologically. Size was about 6 centimeters, single lesions 43%, multiple 56%, and equally distributed amongst child puke A, B, and some patients with child's puke C. Data from South India of 339 patients published recently showed that NAFLD-associated cirrhosis was almost 50% in their series, followed by hepatitis B 17% and HCV 6%. Most of the patients that they came to them was BCLC C and D. Alpha-fetoprotein of more than 400 was seen only in 49%, cirrhosis was seen in 46%, metastasis 22%, tumor thrombosis 17%, and they could, by way of surveillance, pick up 26% of cases. So by and large, there may be some regional differences, but fatty liver disease has taken over the cause for HCC in the country. Now, we are all familiar with the risk factors producing HCC. Hepatitis B used to be most prevalent. In India, it has a prevalence of 3 to 4.2%, with the result that of the total population that we have, 40 million cases of hepatitis B are there. And most of the HCCs in the centers couple of years ago showed that 70 to 80% were because of hepatitis B. And one of the reasons what was said then was the vaccination was not given adequately to the at-risk population and in the children. But over the years, this has improved. However, the risk was higher in patients with cirrhosis associated with HIV, HCV, chronic alcohol, obesity, diabetes mellitus, and aflatoxin. And there were some cases of non-cirrhotic HBV, HCC also, and this was correlated with E antigen positivity, hepatitis B virus, D genotype, high HBV DNA levels, and persistently raised ALT and high levels of HBsA antigen. HCV prevalence in the country is less than 1%. Non-cirrhotic HCCs are 10% associated with advanced fibrosis. All others have evidence of cirrhosis. And even with the availability of directly acting antivirals, the incidence of HCC has come down, but certainly one needs to be very cautious and do surveillance studies in these patients who have had SVR following therapy. However, the risk factor in HCV cirrhosis leading to HCC was low albumin, low platelet, alpha fetoprotein post-treatment still being high, and no reduction in HCV RNA. Alcohol is another etiological risk factor, and with age it increases the chances of development of cirrhosis and HCC. There's no information on the quality and duration of alcohol intake, but the 10-year cumulative incidence is 6.8 to 28% from different series. And whenever it is combined with hepatitis B and C, the chances of HCC goes up. NAFLD has now surpassed all these virus-related HCC. And initially we used to label them as cryptogenic cirrhosis, and the risk is likely to increase even further. Almost about 4 to 27% in some series have reported HCC in patients with cirrhosis. Hence, surveillance now is extremely important in this group of NAFLD-related cirrhosis. There are about 20 to 30% of patients in whom HCC is without the development of cirrhosis, but there is evidence of increased fibrosis in them. Obesity is an important risk factor for NAFLD-associated cirrhosis and HCC, and they have found males with a BMI of more than 35 have a 4.5 time increased chances of HCC. And again, important cofactor is HBV and HCV. We know that obesity mediates inflammation for HCC via IL-6 and TNF, and meta-analyses have shown that the risk of HCC in obese individuals is about 83% and overweight is about 48%. And even those who don't have cirrhosis, there is 1.3-fold increased in chances of developing HCC. In US, Japan, UK, Germany, it has been clearly shown that the liver transplant registry earlier on primarily had HCV and alcohol, but now NAFLD has taken over in the last 1 decade or 2 decades, wherever the data is available. In UK, it has gone up from 10% in 2000 to 34% in 2010. And the Indian series also has shown that 38% of the liver transplanted patients have evidence of NAFLD. Diabetes, which is the reason for NASH, systemic review has shown that whenever a person is having cirrhosis, the odds ratio for HCC is about 2.5 times. Again, combination of HBV and HCV would increase the chances of HCC almost with a hazard ratio of 1.21 and 4-fold increase in the chances of HCC. So you have diabetes, obesity, important factors for the development of NAFLD. And this is something which you all must have read recently, the ICMR data. India is now the capital of diabetes, and this information showed that 11.4% of the Indian population has diabetes, hypertension 35%, obesity 40%, and it's more common in females, and hypercholesterolemia in about 25%, with the highest prevalence of diabetes and obesity in Goa, Pondicherry, and Kerala, and more so in the urban population. Now, with this data, we are likely to get more and more cases of HCC. Some correlation of HCC has been reported with gut microbiota and bile acid metabolism, some information on PNPLA3 polymorphisms as the risk factor for development of HCC, and genotype being the most important one. And hence, surveillance is important, especially in patients with advanced fibrosis. And one may have to look for non-invasive markers. And there have been some preventive studies in patients with NASH by the use of statins, metformin, aspirin, and GLP-1 agonists, but they cannot be, they have not been recommended. But there are studies. Autoimmune hepatitis, HCC, may happen more often with cirrhosis, but one of the risk factor is the use of aflatoxin. Somehow we don't talk much about it now, as we used to talk about 30 years ago. Basically, this is a fungal toxin which is produced in the stored grains. And histology of HCC in 2007, in one of the studies, showed that almost 58% had evidence of aflatoxin in their histology samples. Smoking is another factor, but there is no information of its impact on NAFL, but certainly increases the chances of HCC. Some genetic risk factors for development of HCC have also been studied, but I would not dwell on that. What I want to say here in the penultimate slide is, we know surveillance and screening is being done at a lot of centers, but somehow the pickup rate is not very good. Is there a place for scores when these patients come to us? Gallard score, page B, M-page, MAP score, AASL score. All these are very simple scores, except for Gallard, which has the maximum validity in different countries. Unfortunately, we don't do AFPL3, which is a part of the Gallard score. And lastly, even machine learning has been used in a few centers to predict HCC. Dr. Amit is going to talk to us on screening and surveillance, so I won't go deep into this. But finally, I would say that the incidence of HCC is rising. The commonest etiology is fatty liver disease, and this possibly is because of obesity and diabetes. Hepatitis B and C as a cause of HCC is slightly down, and this is because of good vaccination for HBV and treatment. But surveillance should be done in all our patients with high-risk population. Unfortunately, the results of surveillance in picking up early HCCs are in a very few centers. So thank you very much for this listening to my talk and setting the ball rolling.
So, thank you, Professor Chawla. And the risk factors, as Professor Chawla has shown, one of the major risk factors which has been identified is fatty liver disease and lifestyle disease. You have increased diabetes, increased obesity, lifestyle, increased sedentary habit, and itself, it causes actually increased incidence of all cancer. And since it being reported by liver hepatologist, we see more of the liver cancer. And these are preventable disease. Having said that, any particular points or questions anybody wants to comment?
Subrat, one point which I forgot was the Bhatt-Chiari syndrome also has a risk factor for HCC, which has been reported from your center.
Yeah, we have reported that about 20 years cumulative incidence of Bhatt-Chiari. It is not decompressed, angiographically decompressed. is about 10.5%.
Sir, now that the nomenclature of NAFLD is changed to steatotic liver disease, so do you think that will make an impact on this etiology of HCC? So it's now MASH, alcohol, then you have with viral hepatitis. So and so
See,
on.
any type of steatotic liver disease would have uh, diabetes and obesity as one of the components of steatotic liver disease. So, personally speaking, we'll have to look at this aspect, but I don't think it would make a significant difference in the development of HCC. We'll have to be cautious in all steatotic liver disease patients, especially who have evidence of steatohepatitis.
Excellent presentation, sir. Recently, Lancet published the ICMR data on diabetes, and we are the diabetes capital of the world. So, as the diabetes will increase, we'll see more and more HCC. So, I have one question: whether the control of diabetes also matters. Suppose person who is having good control will have a lesser incidence of HCC as compared to those who have higher HbA1c throughout.
Unfortunately, this information is not available. Uh, I can quote one study which I'm aware of. Patients with compensated cirrhosis, if they were given SGLT2 inhibitors, the chances of developing decompensation and HCC was found to be decreased. Logically, I think it should make a difference, but there are no studies to support that.
And the second question, and most of the scores you had shown, I think Dr. Amit will also see. So why is diabetes not a risk factor in those scores? Like albumin is there. And
That's a very
gender
important
and-
point. Very
Okay,
important point. But I hope Amit speaks to us about the scores. Ultrasound and alpha fetoprotein may not pick up very many cases, but this is simple and one should be taken up.
Can I say this? Excuse me.
Yeah, please.
Regarding Dr. Ashish's
after
question
the
about diabetes,
DA treatment in patients with the Hep C, traditionally speaking, the prevalence of the HCC goes down, and there is no recommendation regarding the surveillance of HCC in these patients. But recently, I had a chance to review all the ASLD abstracts, and it was very prominently discussed in that many abstracts on this, that they looked at the prevalence of HCC even after the clearance of the HCV, and they found that it is slightly higher. So I don't know, the guidelines still don't advocate the surveillance in those who have cleared the virus, but maybe this is going to be there.
You are
Dr.
right, Dr.
Vinender.
Singh. I think Professor Chawla will say, in patients with HCV who has cirrhosis and had SVR, even though the risk comes down marginally, the risk doesn't go away. And they are likely to develop liver cancer on long term. About in cirrhotic, annual incidence in HCV cirrhosis is about 1 to 4%. But if you see after SVR, it continues to be, right, about 1 to 4, 1 to 3, 3.5%. There is a lead time bias, but it doesn't rule out at all. So all guidelines recommend that in HCV cirrhosis, even after SVR, they should be kept on surveillance.
I'm not talking of the HCV cirrhosis. I'm talking of the non-cirrhotics.
All
Those who had the HCV
all
infection.
non-cirrhotic patients,
Yeah.
even in hepatitis B or fatty liver disease, has some degree of advanced fibrosis. And there have been recent studies where it has shown about 70 to 80% of them has advanced fibrosis. Once there is a fibrosis, there is a matrix modulation in the liver, and there is a replication, and there will be genetic alterations. HCC, we know, is a multi-step genetic process. Starts with one, then another, then another. And when you have advanced fibrosis, it started actually. That's the problem in patients with advanced fibrosis. What we call as a non-cirrhotic cirrhosis is an overt clinical feature or biochemical feature or imaging feature or even histology, right? It's, say, stage 2 fibrosis, right? It will not cause cirrhosis in metabolic state. So they have advanced fibrosis. There is matrix modulation. So they are always at risk.
Yeah.
Dr. Virender,
Thank you.
Dr. Virender,
Yeah.
the 2023, the ASLD surveillance guidelines for HPV attained SVR, if they are, even if they have advanced fibrosis but no cirrhosis, they are not recommending surveillance. So I personally feel they should be under surveillance, but these are the latest guidelines for non-cirrhotic, even for advanced fibrosis post SVR, they are not recommending surveillance.
I'm talking of the abstracts which I reviewed, the next ASLD. And they were all abstracts from the US, majority, a large studies. And in that I found that in spite of the clearance of the HCV, they saw the higher incidence of the HCC.
Yeah.
Yeah, you are all right, but you cannot put everything into one basket. With
Yeah.
HBR, with moderate fibrosis, fibrosis will reverse. There are associated risk factors with lifestyle disease like diabetes or obesity, right? So there are multiple factors in HCC. But the fact is, once liver is damaged, you should be careful. And the guidelines are coming on a very tubular fashion, depending upon the expertise in that discipline.
Yeah, thank
But
you.
as clinically you suggested, they are
Regarding Dr. Ashish's question about the diabetes control and the risk of HCC, so I think it is the worse or the poorer the control of diabetes, higher the insulin resistance, higher the levels of insulin, hence higher the chances of HCC. So in other words, if you control it theoretically, logically, the incidence of HCC should come down in a controlled diabetic.
again, that's a very complicated area. There's a different discussion. Let us not go into the details. Right.
I also
Because
want
GLP-1 and SGLT2 on the one hand and insulin therapy on the other hand, two different things in diabetes. If you tie portal vein liver atrophies, because insulin is a trophic factor, it causes growth. Right. And
also
diabetes itself is a risk. You are treating with insulin, the data will come out. So this is a very complicated area. I cannot give a statement at this moment.
also
Insulin therapy in chronic pancreatitis has been already shown to cause pancreatic malignancy, higher incidence of pancreatic malignancy.
Sir, I also wanted to mention the risk of co-infection hepatitis B, C, including HIV. This is a very fibrogenic virus, and the rate of going into cirrhosis and HCC with HIV superadded on B or C is also a great risk factor. Normally, HCC would be seen in about 2% of cases of liver cirrhosis per year. In these co-infected patients, especially with HIV, the incidence of incidence of HCC may be as high as 5 to 6%. So that is another risk factors. Also wanted to mention about pediatric NASH. We should not forget that pediatric NAFLD is also an emerging concept, same component of metabolic syndrome, but much higher incidence of NASH seen in pediatric NAFLD to the tune of 25 to 50% of NASH is seen. So it's a more serious complication in pediatric NAFLD.
Thank you, Professor Chawla. I think we should go to the next.
I think we'll listen to Amit on
Yeah.
the advanced fibrosis
Yeah.
in HCV and NAFLD.
That's right.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. For the next session on screening, surveillance, and diagnosis of HCC, I would like to invite the chairpersons, Professor Ajay Gulati. He's professor in the Department of Radiodiagnosis at PGI Chandigarh. Professor Monish Chabra, Director Fortis. Dr. Madhumita Prem Kumar, Associate Professor, Department of Hepatology, PGI Chandigarh.
Good evening, everyone. Good evening, everyone. So it's a pleasure to invite Dr. Amit Singhal, who is the medical director of the Liver Tumor Program and Chief of Hepatology at UT Southwestern Medical Center, Dallas. And I know all of us are keen to hear to his talk, and welcome, Dr. Amit.
Thank you so much. I'd like to start just by thanking INASL for inviting me to be a part of this. I'm quite excited to be here and talk about screening, surveillance, and diagnosis, topics that are near and dear to my heart. Also, I'd like to thank Dr. Chawla for giving that great talk on the epidemiology of HCC, and I think highlighting a couple of the areas where our talks will interact in terms of some of the ongoing controversies in terms of where does the epidemiology start to inform our screening and surveillance practices. So hopefully I'll answer some of the questions you raised, and if not, we have time for the Q&A. So here, let's start with the some of the pictures from the AASLD guidelines, which are just now available online in hepatology. We talked about the at-risk population, and you can see here that the at-risk populations that we really outlined in the AASLD guidelines primarily focus on the historic populations that we've known to be at risk. So we know that the highest risk categories continue to be those with cirrhosis from any etiology, viral or non-viral, and we've already talked about the importance of continuing surveillance in those patients with a history of hepatitis C cirrhosis post-SVR. And then these at-risk populations with non-cirrhotic hepatitis B, using, once again, some sort of demographic factors, age, sex, country of origin, but this year we've also built in the PAGE B score. So we built in a risk score that has been validated in both treated and untreated patients. So those with a PAGE B score 10 or higher have a sufficient risk to warrant HCC surveillance. In the AASLD guidance table, you can see here that we do not recommend HCC surveillance in patients with hepatitis C or NAFLD in the absence of cirrhosis, including those with advanced fibrosis. So stage 3 fibrosis, both in hepatitis C with viremia or post-SVR, as well as NAFLD. And the reasons that we did so were there was recognition, as we've already heard, that there's a significant proportion of patients who do have advanced fibrosis, so do not have cirrhosis at the time of HCC presentation. Once again, as we've heard, somewhere upward of 20 to 30% of these patients, particularly in NAFLD, can present in the absence of cirrhosis. However, when we take a look at the cohort studies of the large populations who have NAFLD in the absence of cirrhosis, the annual incidence is quite low. And this was nicely shown from a large VA cohort study from the US, where the annual incidence of HCC fell far below the 0.2% annual incidence you need to achieve cost effectiveness. We've also heard of the difficulties of implementing surveillance programs in those at highest risk. So cirrhosis, non-cirrhotic hepatitis B, let alone trying to implement these surveillance programs in this large NAFLD population in the absence of cirrhosis. And so at this time, the feeling from the committee, or the beliefs from the committee, was that we should not do HCC surveillance, but this is a population in whom risk stratification strategies are needed. And so if we can identify risk stratification tools that can identify high-risk patients, we can then better target surveillance in the future. And so when we talked about the at-risk populations, this once again was largely done with this sort of paradigm of weighing both benefits and harms. And so when we think through surveillance, we often think through the goal of early detection, curative therapy, improved survival, and we clearly need to do better. So we've already heard, once again, that a minority of patients are found at an early stage. But as we'll talk about, we also have to be cognizant that there are potential harms. So there is the potential for diagnostic evaluation, there's the potential for psychological distress, and the potential for financial burden, particularly in patients who are paying out of pocket. And these things can be influenced by many different risk factors, not only the incidence, but some of these factors that we talked about in the guidance in terms of liver dysfunction, medical comorbidities, age, and patient preference. And so when we think of this paradigm of overall value, this really informs the at-risk populations. Now, just a couple slides in terms of the benefits and harms. Here we can see data from a systematic review and meta-analysis published a year ago now in Journal of Hepatology, where we can see that HCC surveillance from a patient with cirrhosis perspective is consistently associated with clinical benefits. So consistently associated with improved early detection, curative therapy, as well as overall survival. And you can see here the association between surveillance and improved overall survival consistently shown across studies. And when you take a look at the subset of studies that adjust for lead time and length time bias, there continues to be an association between surveillance and these improved clinical outcomes. So thereby, surveillance does appear to have benefit in this patient population. Although, as I mentioned, that this has to be weighed against potential harms. And this is a taxonomy of harms that has been applied to cancer screening programs across the board. Colon cancer screening, breast cancer screening, prostate, and is now starting to be applied to HCC surveillance. And you can see here, once again, that these harms can be classified into physical harms, financial harms, and psychological harms. And you can see that this can be related to harms that occur at any point across the continuum and can be either mild or moderate or severe in severity. Now, when we take a look at screening harms for HCC surveillance, we find that there's 4 studies to date that have looked at physical harms, so diagnostic evaluation for false positive or indeterminate results. The good thing is that we see that physical harms occur in a minority of patients, somewhere between 9 and 28%, and most of the harms appear to be mild in severity, single CT scan, single MRI. And this is sort of acceptable physical harms. At the time of this meta-analysis, there was no data on financial harms or psychological harms, but we just published the first study on psychological harms of HCC surveillance, now in Prasad Hepatology, where we found that those patients who have false positive or indeterminate results do have mild increases in anxiety or depression. These tend to be short-lived as the diagnostic evaluation is completed, but those patients who have a false positive and undergo repeated diagnostic testing, for example, getting into a cycle of evaluating LIRADS-3 or LIRADS-4 lesions, can have heightened anxiety and depression that last over longer periods of time. Likewise, we're in the process of publishing the first data on the financial harms of HCC surveillance, and we find that financial harms can include direct costs, so co-pays or out-of-pocket costs, also indirect costs from parking, and opportunity costs from taking time off work to attend these visits. So, attending the ultrasound, the CT, MRI, etc. Once again, with variation in that financial harm depending on how long that diagnostic evaluation occurs. Now, when we talk about what the AASLD recommendation for HCC surveillance, the AASLD now recommends ultrasound with AFP. So as many of you know that have been following this literature, the recommendations have gone back and forth, ultrasound alone, ultrasound with or without AFP, but as the data have evolved, it was felt in this iteration that there was sufficient data to now recommend the 2 tests be used in combination, and this be performed on a semi-annual basis. The AASLD at this time, as I'll discuss, does not recommend routine use of CT or MRI-based surveillance or the routine use of tumor biomarkers outside of AFP. And I'll go through the data for those modalities. I do think that these are promising, but the feeling at this time, the belief at this time, was that these were not sufficiently validated, and I'll go through that discussion as well. So first, talking about ultrasound with or without AFP, and so these are the data for ultrasound alone. You can see here that the sensitivity of ultrasound for early stage detection largely varies across studies, highlighting its operator-dependent nature. Second, we can see that the sensitivity of ultrasound for early stage detection is insufficient. So the sensitivity of ultrasound for early stage HCC detection, only 47%. We clearly need to do better. When we take a look at the data for ultrasound with AFP, we can see that AFP significantly improves sensitivity for early stage detection across studies. So the sensitivity of ultrasound with versus without AFP was 63% versus 45%. Small decrease in specificity, but the overall diagnostic odds ratio higher with the 2 tests used in combination. These data and others were plugged into our cost effectiveness model, as you can see on the right-hand side of your slide. And the combination of ultrasound with AFP was the preferred strategy in most simulations, over 80% of simulations, at the most typical cost effectiveness thresholds of 100,000 or 150,000. So ultrasound with AFP being the preferred strategy at this time. Now, once again, there's clear recognition that we must do better, right? A sensitivity of 63% is not where we want to be. We clearly need to do better. And as already heard about, that, you know, I'm a big believer in biomarkers. We just need these to be better validated before we use them in clinical practice. So what do I mean by when I say these need to be better validated? There's a set rubric of how tests must undergo validation that has been established by the Early Detection Research Network, once again established across different cancer types. And we've now published a paper showing how this applies to HCC surveillance and the steps needed for HCC validation. Most of the biomarkers and most of the strategies, whether abbreviated MRI or the biomarkers, including GALID, liquid biopsy techniques, have largely undergone phase 2 case control evaluation, which overestimates performance given spectrum bias and inclusion of people on both sides of that spectrum, cases that are definite cases, controls that are definite controls, and avoiding the gray zones, thereby overestimating performance. And so it's important that they undergo both retrospective cohort studies using stored samples as well as prospective evaluation. And that prospective evaluation really is essential to establish the clinical utility, both in terms of stage migration and reduced mortality. And that's really what I mean when I say these need to be better validated, is prospective validation prior to use. The other thing that we need to think beyond is we need to think beyond simple test sensitivity. We need to think of things like utilization. And you can see here on the right-hand side of the slide why it's important to think through ease of use and in adoption in clinical practice, because you can take a more sensitive test that is difficult to apply in clinical practice, so low adherence, and you can do worse than a test with lower sensitivity but increased ease of use, where you thereby increase the number of patients detected at an early stage. So one would argue test 1 simulates what we would expect with abbreviated MRI or MRI-based modalities. High sensitivity, but difficult to apply in clinical practice, and so out of 100 people, you would only detect 21. Whereas test 3 is more like what we would see with a biomarker, where you may see lower sensitivity than what you see with MRI, but you'd see markedly increased utilization and increased use of ease, and thereby detect more people at an early stage. And that's why I personally am a big believer in these biomarkers as really the future of how we should perform HCC surveillance. Now let's go through some data for these emerging modalities. So the first is MRI. So MRI is probably the best test that we have from a test performance perspective. So this was shown in a South Korean study, prospective cohort study, 407 patients, followed over 1.5 years, semi-annual ultrasound and MRI done in all patients, 43 patients diagnosed with HCC. Sensitivity of MRI, 86%, significantly higher than that of ultrasound, as well as higher specificity, 97 versus 94%. So the test performance characteristics significantly better for MRI than ultrasound. However, I've already talked about the importance of adoption and ease of use. And when we think of things like MRI capacity and costs, this is really not a feasible strategy when we think about applying it to the large at-risk populations that we must care for in clinical practice. Now, some radiologists will argue abbreviated MRI could solve some of this, right? So you take a 45-minute exam, you select certain sequences, and you thereby decrease the test time, the in-scanner time, to 15 minutes. You could thereby decrease costs. Here we show data from a multi-center retrospective study, 161 patients who had pathologically confirmed HCC, and 138 patients with cirrhosis but without HCC. 129 underwent resection, and that primarily forms the primarily forms the HCC cohort. And then you have 170 that underwent transplant, some HCC, but largely the control population. And we can see that the sensitivity and specificity of abbreviated MRI is high, but it is not consistently true across the board, where you see lower sensitivity in patients with advanced liver disease, primarily those with Child-Pugh B or C cirrhosis. Moving on to the biomarkers, GALID is one of the most promising biomarker panels that we have so far. This has completed phase 2 and phase 3 biomarker validation. In the table, you can see data from the phase 2 case control data, where GALID had sensitivities of 60 to 80%. This has recently completed phase 3 cohort evaluation in the NCI HEADS study, 1,484 patients, 107 incident HCC, and GALID had a sensitivity and specificity in this study of 65 and 82%. So this is very good test performance showing high sensitivity and specificity. This is now moving into prospective validation. So here you can see the National Liver Cancer Screening Trial, which is starting in the United States. So 5,000 patients that are being randomized to ultrasound with AFP versus GALID alone, with a primary endpoint in reduction in the proportion of late-stage HCC. If this trial is positive, this would be sufficient to move GALID into clinical practice as a standalone test, not as an add-on to ultrasound. Last couple slides. The other thing that we should note is that those patients who have visualization score B or sub-centimeter lesions on ultrasound have a low risk of developing HCC, and those patients are recommended to stay on ultrasound surveillance, not move to diagnostic evaluation. This was recently shown in a multi-center retrospective cohort study from the US, where we took a look at patients with sub-centimeter lesions. So 746 patients who had sub-centimeter lesions across multiple centers, and we found that actually the risk of HCC in these patients was low. So the incidence of primary liver cancer, 25.7 cases per 1,000 person years. So about just over 2% in terms of an annual risk of developing HCC. However, we were surprised to find that only 28% of patients underwent guideline concordant surveillance with repeat ultrasound within 3 to 6 months. You can see that a large proportion of patients underwent diagnostic CT or MRI, thereby once again increasing the harms that we see with surveillance and thinking about the importance of staying on guideline concordant care with repeat ultrasound-based surveillance given the low risk of HCC in a sub-centimeter liver lesion. If this lesion grows above a centimeter, then those patients should go on to diagnostic imaging with CT or MRI. The other thing that we noted was that those patients who have poor visualization, so visualization score C on the ultrasound, those patients should undergo screening contrast enhanced multiphasic MRI or CT, and this is based off the low sensitivity of ultrasound when you have poor visualization. So we know that nearly 1 in 5 ultrasounds are suboptimal for HCC screening, have poor visualization, and we know that this has a higher proportion in patients with Child-Pugh B or C, obesity, or non-viral etiologies. Once again, we've already heard not only the current time of HCC, but the future of HCC. So ultrasound performance is only expected to get worse over time, really highlighting once again the importance of us validating these alternative strategies. And we know that if you have severe visualization limitations, visualization score C, your sensitivity of ultrasound is not for 50% or 60%. Your sensitivity of ultrasound at that point is only 25%. Clearly need to think of other strategies, and that's why the AASLD recommended a screening, CT or MRI, if you have severe visualizations, once again, this visualization score of C. The last couple slides here in terms of diagnostic algorithm, we said that the diagnostic algorithm for those patients who are found to have a liver lesion, a centimeter or greater, should thereby be evaluated using cross-sectional imaging, diagnostic MRI or CT, and the AASLD refers to the LIRADS features in terms of diagnostic criteria. It is important to note from a hepatitis B perspective, and I understand hepatitis B is decreasing over time, but there's still today a large proportion of patients who have hepatitis B related HCC. It's important to remember that if your page B score is 9 or less, the LIRADS criteria has not been validated. It's only been validated in those patients who have a page B score of 10 or greater. And so thereby, if you have a patient with hepatitis B who has a liver mass on diagnostic CT or MRI, it doesn't matter if it has enhancement and washout, those patients warrant a biopsy for definitive diagnosis if your page B score is low. ASLD, once again, has adopted the LIRADS criteria for diagnostic imaging. This includes features including size, the presence of arterial phase hyperenhancement, delayed washout, capsule threshold growth, and you can thereby classify lesions going from LIRADS 1 to LIRADS 5, LIRADS 3 being intermediate, LIRADS 4 suspicious, LIRADS 5 definite for HCC, positive predictive value 95%. Now, one of the things that we talked about is that we did say LIRADS 3 and LIRADS 4 lesions are commonly found in clinical practice. This is found in about 20% of patients undergoing surveillance who undergo diagnostic imaging. And so we've given explicit guidance in terms of the follow-up for these lesions. So we know that LIRADS 3 has an intermediate risk of HCC, somewhere around 35%. Patients with LIRADS 4 have a high risk of HCC, somewhere around 65%. And so these patients should not be ignored in clinical practice. And so the recommendations are that those patients with LIRADS 3 typically be followed by cross-sectional imaging. If they're very large, 2 centimeters or greater, one can consider a biopsy for definitive diagnosis at that time. Patients with LIRADS 4 should undergo close interval imaging with repeat imaging in 3 months, given the high risk of HCC as shown by this systematic review and meta-analysis. If they are a larger LIRADS 4 lesion, one once again can consider biopsy for definitive diagnosis, but these patients should be followed. The vast majority of LIRADS 4 will declare themselves as HCC, typically within 6 months of detection. So in summary, the value of HCC surveillance is based on a balance of benefits and harms. This balance is likely impacted by the choice of surveillance modality. Currently, we should use ultrasound plus AFP despite being imperfect based on the current level of evidence. Although, once again, emerging biomarker and imaging-based strategies are available. We just need higher levels of validation, and we should consider issues of implementation adherence before we start using this in clinical practice. ASLD has adopted LIRADS for the diagnostic criteria, and as I mentioned, LIRADS 3 and 4 have an intermediate risk of HCC and must be monitored. Thank you.
Thanks for a very comprehensive overview of the current guidelines which the ASLD advocates. I'm sure there would be many questions and concerns with the audience. So if we can have, sir.
Excellent talk, Dr. Amit. So I have 2 questions. One, you have put NFLD as patients having very low, less than 0.2%. But all NFLD are not same. There are patients who have high fibrosis, especially determined by LSM values, fibroscan values.
Yeah.
So between 10 to 15 and on those. So wouldn't they merit by this? And the second question was, how far is in clinical practice is liquid biopsy based surveillance? Yeah. So these 2 questions.
Yeah. So you saw that I already went over time, so I had to sort of make executive decisions of what I should not include or what I could not include. But the first question in terms of like NAFLD, when I say non-cirrhotic NAFLD, clearly a very large population, and to your point, there's clear variation in risk across those gradations of stage 1 versus stage 3 NAFLD. The studies that have been done, when they take a look at this, they've looked at all the available subgroups, and all the available subgroups, none of them achieve an annual incidence of 0.2% or higher. That being said, I think the number of studies that have good characterization of stage for these non-cirrhotic NAFLD, relatively low. I think when we've looked at this, what we say typically is if somebody comes in and they have stage 3, in terms of an assessment, but you think that they may have stage 4, then I think that it's worth considering this on a case-by-case basis. However, when we take a look at the larger population of stage 3 NAFLD, I think at this point we don't have sufficient data to say that this should be adopted in those patients. And one would argue, given the low incidence, the overall value, the balance of benefits and harms probably is not sufficient to warrant HCC surveillance in those patient populations. Now, once again, the other thing that I would say is a stage assessment is, a cross-sectional assessment. One key thing here is for us to use some of the therapies that we've already heard about. Hopefully we see improvements with weight loss, some of these other medications, and we can actually go from a stage 3 maybe to a stage 2. Many of those patients, unfortunately, will not do so. They will continue to progress, And I think the key thing is to identify them when they do progress and then start them in a surveillance program at that appropriate time. The second question was about liquid biopsy techniques. And so we've seen some case control data for liquid biopsy techniques. We've seen the methylated DNA marker panel from Exact Sciences, and we've seen similarly another methylated DNA panel from Helio that have undergone case control studies in a multi-center US basis. Those studies have shown sensitivities and specificities higher than AFP, not significantly different than that of GALID. So you essentially get the same squeeze as GALID, much higher cost. And we know that Helio has completed their phase 3 evaluation. They completed this months ago and nobody has heard from the company since. You can sort of make your own conclusion what the data probably showed. Exact Sciences is completing their phase 3 evaluation, their cross-sectional study at this time. We don't have that data. So I think that we need to see further validation, but I think that's where those data stand right now. I will say one that I'm particularly excited about, although early stages, is the Delphi. So it takes a look at fragmentomics. It was published, I think, in Cancer Discovery just this past year. So it takes a look at the fragment size, not just sort of the methylated DNA markers. And that one showed AUCs of like 0.95 or higher, including for early stage disease. Very small numbers, needs to be validated in much larger cohorts. But that one uses a different kind of technology, and at least the small data that exists appear very promising.
So I must thank really well presented, and thank you for, and congratulations for the publication on guidelines. I have a question, rather two questions. First question is regarding the cost effectiveness thresholds. Do you think that varies country to country? And for the country like India, where the ultrasound is very cheap, 100 rupees or less than $1. So what do you think about that? Considering all the scenario into account, and F3 fibrosis, as Dr. Acharya was discussing early today, that whether F3 fibrosis, even if they have a minimal risk, so do these patients undergo the HCC screening? That is number one. And the question number two is, as you mentioned, that ultrasound and AFP taken together, that meaning thereby that addition of both ultrasound and AFP taken together increases the sensitivity. Is it either ultrasound or AFP, or is it combination? Because combination will tend to decrease the sensitivity and increase the specificity.
Yeah, I'll do the second question first, just because that's, so it's really when I say the combination, it's not both being positive, it's one or the other. It's one of the common mistakes I see, where when we say this, that people do the ultrasound and the AFP, so they perform both. But then if the AFP is high, the interpretation is, well, the AFP is high, but the ultrasound's normal, so I won't do anything. So the only way that you increase the sensitivity is if you act diagnostically if either are positive. So if the AFP is elevated or it's rising, and I think that's one of the key things. Once again, didn't have time, but longitudinal assessment. So if you go from 4 to 7 to 11, that's actually probably more concerning than somebody who's been sitting around 19 stably or 25 stably. So rising AFP, but if you see, once again, either being positive, you should go on to diagnostic testing. The first point is very well taken. That these cost effectiveness models all have assumptions. They have assumptions in terms of the cost of ultrasound, the cost of diagnostic testing. And those vary from country to country as well as within countries. So, within the US, we had to choose a set point, for example, for cost of MRI, although there's huge variation. So like at our center, we can get a diagnostic MRI for about, less than $1,000. So it's right around 800. But in California, that same MRI costs $3,000. So you can see even variation within the US, and we had to choose a single point estimate, and then we do sensitivity analysis around that. Now, once again, you're talking about markedly different costs. We assumed a cost of $250 to $300 for an ultrasound, and you said it costs 100 rupees? Yeah, so markedly different costs. So it changes the cost effectiveness in terms of doing this, and so each country would have to assess, the cost effectiveness of these strategies in their own populations using their own internal costs. It may change the cost effectiveness of doing this in different populations. However, I would argue it doesn't change the overall value. You still have those other issues in terms of harms when you take a look at sort of how many HCCs you're detecting for the number of false positives. I would argue that when you're taking a look at it, let's take the stage 3 NAFLD population. So ultrasound-based surveillance. So you're going to have first, you're going to have a low incidence rate. You're going to have poor quality ultrasound because you have high obesity and you have high steatosis, which both impact your ultrasound quality. So you have low incidence, you have a poor quality exam, and you're going to be doing a lot of diagnostic testing. So you take a 100 rupee test, then follow it up with an MRI. I don't know how much the MRI costs, but then you thereby increase the cost of doing this. You increase the anxiety of that patient, you increase the number of days that that patient's taking off work, missed wages, et cetera. So there's a lot of extra sort of downstream costs and harms that go into this beyond just the ultrasound itself.
And just one another philosophical thing that, patients, this strategy should be applicable at a population level. Yes, true, agreed. For a patient individual's perspective, yes, definitely there is a difference there. So the patients who are coming to tertiary care hospitals, should this strategy be applied first? Second, HCV post-treatment achieved SBR, still they are F3 fibrosis. They are kind of different population, and George now has shown at least in one study that they have a higher hazard of HCC related mortality. So do you think etiology specific screening protocols at tertiary care centers needs to be modified?
Yeah, so the guidance and sort of, my recommendations when I stand up here, to your point, are on population basis, right? I mean, this is saying across the entire population of advanced fibrosis, NAFLD, advanced fibrosis hepatitis C, and I say that it shouldn't be done across the entire population. Now, we leave here and we go to clinic and we see individual patients in front of us. And for an individual patient, I can't tell anyone how to act, right? And I myself have to think about what is right for my individual patient. But what I'm saying is that I think on a general basis, we should not be doing this across the board. It shouldn't be considered standard. It shouldn't be considered a metric. Once again, if you see an individual patient and you have a provider intuition that that patient's at high risk for whatever reason, you should do the right thing for your patient. But I don't think you should say F3 fibrosis is high risk for everyone. And so from a population-based perspective, that's where I would sort of, come down on that. Your second question of hepatitis C, are you saying they had cirrhosis at baseline, or you're saying they were always F3?
Post SBR down the line, 6 months down the line, F3 fibrosis persisted. So they had this different combinations, F4 coming down to F3, F1 coming down to F0.
So if you're ever F4, so even if you, when at the time of HCV treatment, if you're F4, even if you have fibrosis regression, you should continue surveillance indefinitely at this point. So many of the HCCs that are found post-SVR are found in the absence of cirrhosis. We even saw this with interferon. If you take a look at the interferon data, there were patients who were found 10 years later, and they often had F1 disease. So you can see regression of fibrosis, but once you achieve cirrhosis, your risk is persistent. And there's data from the VA that shows your risk of HCC is persistently above 1.5% once you achieve cirrhosis. Those patients who never touch F4, they go F2, F3. If you treat them before and they don't have concomitant alcohol or NAFLD, et cetera, and they never touch F4, they don't have a sufficiently high risk to warrant HCC surveillance.
Very, very nice talk. So I have a similar question. So in a tertiary care hospital, if you see a patient for the first time who comes with decompensated cirrhosis, what is your strategy? Do you do just an ultrasound, a cross-sectional imaging, or how do you follow these patients?
So I'll tell you what we do, and once again, understanding there's variation and there's other reasons why you may consider cross-sectional imaging. Our strategy is to consider ultrasound as the standard, whether you're Child-Pugh A, Child-Pugh B, and then we take a look at the visualization. So if you have an ultrasound and you have a good quality ultrasound, good visualization, we say that's sufficient. Now, of course, there's many other reasons why you may choose to do a CT scan, right? So you do the ultrasound, they have a portal vein clot, so you need to evaluate that. You would get sort of further imaging. Patients undergoing transplant evaluation, we need to see anatomy. We would do a CT scan for that. So there's other reasons why somebody may need cross-sectional imaging in the setting of decompensated cirrhosis. But if you're talking about simple HCC assessment, that's the sole reason you're doing this, we feel comfortable trying an ultrasound and assessing visualization. Understanding risk factors for poor visualization include obesity and Child-Pugh BC cirrhosis. So you may do this, your radiologist tells you, I didn't have a good visualization, and then you go to cross-sectional imaging. But we give ultrasound a shot.
Excellent talk, Dr. Singhal. Is there a role of PIVCA in screening of HCC? We see a lot of patients with normal AFP and high PIVCA with a normal radiology. How do you deal with these patients?
Yeah, I think my role on the protein biomarkers, AFP, AFPL3, DCP, I think there's different ways you can assess them. And so, the most common, the historic way of assessing them has been taking a look at, combinations of two, AFP, Pivica, or AFP, AFPL3, DCP, doing all three, and taking a look and saying if any is positive, then I'll go on for diagnostic evaluation. The studies that have looked at this and compared that strategy versus incorporating them into a risk score or a sort of surveillance score like GALAD. I know GAD is another one that exists as well. When you take a look at this, those scores do better than using the three biomarkers in isolation. And so, once again, from my standpoint, I think the most sort of promising are those scores, whether GALAD or GAD, and we have to see how this pans out. But that being said, I don't use those in my clinical practice today. I think we need to validate them further, and then if that gets validated, which I'm hopeful for in this trial, then we're hoping to move this as standard of care practice, removing ultrasound and moving to a biomarker-only strategy, but we need validation first.
Just a quick question. Any role of post-transplant surveillance of HCC in patients who have undergone transplantation for HCC? We see the explant biology and then decide.
Yeah, so I think Neil Mehta has probably published some of the best data in terms of post-transplant surveillance and how we should do this. And so I'm a believer in the retreat score. And so assessing your explant pathology, number of viable tumors, size of viable tumors in your AFP, and coming up with the retreat score. He's published a paper basically showing that very nicely stratifies your risk of recurrence. And then he's come up with expert opinion based on those risks of what should be your surveillance strategy, whether, no surveillance if you're very low risk, no residual tumor on explant, et cetera, up to doing sort of, those patients who are higher risk and then doing more intensive surveillance after the transplant. But we've now started to report the retreat score on all of our transplanted HCC patients and using that score to guide our post-transplant surveillance. Once again, when you take a look at this, overall value of this, I will anecdote, but I'll sort of highlight. There was a patient who was downstaged, so started actually with a very large tumor, downstaged to transplant, was on the list for 2 years plus with no disease, and then was transplanted and had a retreat score of 0, right? So no HCC on the explant, doing quite well. And despite the retreat score being 0, the provider who was seeing her post-transplant wanted to get surveillance. And then 1 year out, they reported this as a large lesion in the liver, worrisome for post-transplant recurrence, and then was referred back to see me, very anxious going through this whole process. Ended up being a benign sort of, fluid collection after the transplant. But I told her, I was like, they shouldn't have done surveillance because of this, but she lost weeks of sleep going through this whole thing. So I think it just highlights anecdotally why we should be thinking through this overall value. And once again, I've become a big believer. If your retreat score is 0, you probably don't need it. I think your risk of HCC is near 0, and it's not sort of cost effective nor beneficial to the patients, but then you can tailor your intensity of surveillance otherwise, depending on how high your retreat score is.
I think in the interest of time, we need to, finish this session. And thank you once again,
No,
Dr.
thank
Amit,
you.
for a very informative discussion on this topic.
Thank you, Speaker and Chairpersons. So for the next session on staging systems for HCC, INASL Guidelines 2023, I would now like to invite the Chairpersons, Professor Virender Singh, Director at Punjab Institute of Liver and Biliary Sciences, ex-Head of the Department at Hepatology, PGI Chandigarh, Professor Saroj K. Sinha, Professor, Department of Gastroenterology at PGI Chandigarh, Professor Vandana Midha, Professor, Department of Internal Medicine, DMC Ludhiana, and Dr. Nikhil Nandkarni, Associate Director, Max Super Specialty Hospital, Mohali.
Speaker Dr. Acharya.
Thank you very much. So the staging is very important in the management of the HCC. So let us listen the staging of HCC from none other than Dr. S.K. Acharya, who is a pioneer in the field of HCC. Dr. Acharya, please.
Thank you, Professor Singh. Well, by now all of us realize that the diagnostic modality and therapeutic modality in liver cancer has advanced tremendously particularly during the last 10 years. Now, previously, when we used to stage any cancer, we stage to find out the tumor burden, particularly in solid stage cancer. And depending upon the tumor burden, what is the prognosis and what is the possibility of response to treatment? So you homogenize them. And once you homogenize them, depending upon the study, you can stratify the effectivity of therapy, right? As well as tolerability of therapy, depending upon performance status of the patient. And depending upon the tumor burden and response, therapeutic response, the recurrence. This is about solid tumor. Liver cancer is a different ballgame altogether, because liver cancer has underlying cirrhosis and as well as sequelae of cirrhosis, which itself is important. The etiology of cirrhosis, which is very important. And depending upon the underlying liver disease and its sequelae, the prognosis also varies. So even though liver cancer occurs in this patient, it is a solid tumor, where the tumor spread like other tumors, and vascular invasion is a very important thing. Remember, in liver is a very vascular organ, and per minute about 1.5 liters blood flows to the liver, right? Because of sinusoids, hepatic artery, portal vein, hepatic vein. So the vascular invasion means there is dissemination inside the liver, outside the liver. And again, this last thing in liver cancer is the biology, aggressiveness. By now, over a period of time, during treating patients, you know some patients recur. All patients do not recur. Say post-surgical resection, a 2 years recurrence rate is about 50 to 60%, but breast do not recur. But those patients who recur have aggressive biology, which has been also defined. One of them is alpha-beta protein, as has been discussed. There are others, like PET scan, like histology, like vascular invasion, and after downstaging waiting period if it recurs. So taking all these things, right, and taking the advancement of treatment, now the previously untreated patients of liver cancer are being treated with excellent result. Therefore, because of this advancement and understanding, the staging is also changing. During last 4 years, the famous Barcelona Clinic liver cancer staging system has undergone already 4 modifications in last 10 years. Sorry, right? So that's why staging is very important. Now, because it's advanced, there is an effort to treat all, right? But remember, till date, all treatments are directed in cirrhosis with HCC who has good liver function and who have good performance status. The cancer constitutional symptoms is not there. If the liver function is bad, the therapy, both systemic chemotherapy, locoregional therapy, right, or combination of this, multimodality therapy or radiotherapy is not going to help much except transplant. So the first thing is, even though treatment of cirrhosis is advanced, the treatment is directed irrespective of the tumor burden, irrespective of the vascular invasion, right, to a person who has good liver functions and has good performance status. That's the basis. Therefore, the effort to treat all decompensated if the tumor fulfills the criteria of transplant, you treat transplant. And because of the treatment has advanced, treatment allocations are all staging. Over a period of time, there are variables influencing the therapy has been also been identified. Right, besides the stage, biological aggressiveness as I suggested. Now, when you do surgery, they'll have functional result. You may die of following surgery, liver failure. That's important. and future liver remnant, which can be also enhanced today with therapy, as well as his tolerability, that is performance status, how well he is as far as his oncological constitutional symptoms is concerned, which is graded by ECOG, Eastern Cooperative Oncology Group score, which is very well known. So these are the reasons why we stage cirrhosis, which I just discussed. And INASL has taken all these factors. I'm not going into the details. We have recent modification because after seeing all advancement, all staging system, all transplant or treatment allocation system, and also experience from the country combined together has taken into each of this account. That is, what about, I told about tumor, solid tumor, that is tumors, that is tumor burden, number of tumors, vascular invasion, extrahepatic spread, function, underlying liver functions, cancer-related symptoms, that is performance status, and based on this you can prognosticate, and treatment allocation has included the advancement in treatment, particularly in advanced form of chemotherapy, as well as radiotherapy or multimodalities. So we've tried to subgroup them further to provide treatment to give the maximum benefit to a large number of patients. And we earlier know there are 3 systems of staging which not only provides the tumor burden, liver function status, prognostication, but also allocate treatment based on the past experience with prospective data, which has provided basic increased survival data depending upon the stages. So we know Barcelona Clinic liver cancer, which is followed by ASLD or DESL. There is Southeast Asian countries has been since long and very aggressive in treating liver cancer. They resect most of the liver cancer, even though the vascular invasion. So, and second thing, in the West, predominantly HCC data has been derived from HCV cirrhosis, whereas in Southeast Asian country, predominant data has been derived from hepatitis B virus. When HCV cirrhosis decompensate or cirrhosis occur, and hepatitis B, there is a difference. That is a further study. So, Hong Kong liver cancer staging group advocate very aggressive resection therapy, which is followed by APSL. Now, if you see, this is the latest guideline of HCC staging by Barcelona Clinic liver cancer. I presume all of you know this, Barcelona Clinic liver cancer, because this is the major basis of prognostication, treatment allocation, and also recurrent rate. Now, I will go, this is a very busy slide. I will go into, because if you know, BCLC has been divided into early stage, that is small tumor, good liver, less than 2 centimeter, very early stage, very small tumor. Early stage, the number of tumors are more, but they have a defined. The number is limited to 3 and size is limited to 3 centimeter. Now, they have all good, and if the tumor burden has further increased, they call it BCLC-B, right? And if the vascular invasion is there, they call it BCLC-C. And if the liver function is very bad or there is a distant spread, this is called BCLC-D. Now, over a period of time, this was seen, this is not uniform, they are heterogeneous, right? Now, people over a period of time found that another thing in BCLC I must emphasize, if you see up to BCLC, if you see their liver functions are good, they are preserved liver function, and they are treated, and their performance status is also good, right? They can tolerate treatment. So that is a very important component of this. But the tumor heterogeneity and presence of underlying cirrhotic sequelae, the treatment allocation, they varied. Suppose a person has portal hypertension and a MELD score of say more than 9, and you have to resect more than 3 segments, the decompensation rate is more. So depending upon portal hypertension, right, liver function test, as well as, right, for performance status, they subject them to resection or transplant is the best. Markov model is shown
that any patient who can be subjected to liver cancer, subjected to transplant, is the lowest recurrence rate and best 5-year survival rate. But that is cannot be done to everybody. So that is the obviously shortage of demand. So therefore, various form of treatment has been allocated depending upon these basic characteristics, because it will take time to go into the details. This is a very well-known study. What they have done in 22, they have, I told you, good liver function. Good liver function earlier was child say, right? CTPA, which you know, which is less than 6, right? Taking 5 parameters. Now these group of patients are heterogeneous patients, right? Patient has an albumin level of 3.3 and 3.5. They are different. A bilirubin level of 2 and 1.5. They are different. So they subsequently divided these patients of child say who has good liver function, who are treatable patients, by something called ALB score. I will just tell you about ALB score. That is albumin bilirubin score, which is a discriminant equation that is derived. Divided into 3, ALB1, ALB2, ALB3. Even with, say, BCLC-A, if you see, with ALB1, the 5-year survival rate is much better than ALB3. So this is a further thing they have included to categorize liver function. Second thing, BCLC-B, as I told, when the tumor burden is more than 3 lesion, right? More than size is more than 5 centimeters, right? And that is not, they earlier was told, not curable. And this is a part of Milan's criteria for transplant. Now, subsequently, people who are doing transplant, they increase their ambit. They transplanted patients with more tumor burden with excellent result. So UCSF criteria came. So they suggested BCLC-B can be B1, B2, and B3. When B1 is crosses the BCLC-A criteria, that is more than 3 tumor, or size is more than 3, or even single tumor which is more than 5 centimeter, that can be subjected to transplant, and that comes under something called University of California, San Francisco criteria, right? Where the criteria has been increased and with similar result. So they suggested B1 should be subjected to transplant. B2 is a larger tumor burden, where the arterial feeding vessels clearly identified. This is the group which respond to TACE because you can deliver chemotherapy to them, right? This group can be also downstage with this therapy, either TACE or radioembolization or combination of radioembolization to other locoregional therapy like various ablative techniques, and downstage can be subjected to resection or transplant. Whereas B3, it is a diffuse type of tumor with an unclear arterial feed. And there, the chemotherapy, lipoidal chemotherapy or DCB, they do not distribute the therapy well. They do not respond. That has been studied, various studies says. So they suggested systemic chemotherapy, right? But this can be downstage. This can be also brought small by radiotherapy as well as locoregional therapy or combination, and can subject it to curative therapy. So they divided BCLC-B into 3 groups. Third thing they divided, that when we are treating, say, BCLC-A, there is a treatment stage migration, there is a recurrence of tumor or a vascular invasion. You can go to the next stage, that is treatment stage migration, or untreated progression, that is when we are treating and there is no response. You go to the next stage or a higher group of chemotherapy. I told downstaging by using multimodality treatment to offer them curative therapy. Curative therapy by now it is surgery, resection, and transplant, right? Which is not offered to BCLC, B2 or B3, which can be downstage and can be offered to curative therapy. That is because this advancement of treatment, this is the addition to the staging, which also we have used. And systemic therapy, as I told, those diffuse B3 and BCLC-C, that if there is some portal vein invasion, use systemic therapy. There are huge advancements in systemic therapy, starting from sorafenib to atezolizumab to to durvalumab, to tremelimumab, to lipim, multiple. So these are the things, right? However, they have also used radioembolization. I have just noted down below, and downstaging transplant and treatment stage migration or untreated progression, as I suggested. I don't want to go into the detail. Now I told you ALB score. Now you say multiple studies across the BCLC stage. The results are much better in ALB1 in comparison to ALB2 to ALB3. And there are a large number of studies in each BCLC stage. So ALB score, we should, in clinical practice, should be included. However, INASL 2023 has not suggested it, but I think we can modify it subsequently. This is the treatment stage migration which BCLC has given. So, systemic chemotherapy, they have suggested advanced disease, right? That is BCLC, as I suggest, where vascular invasion is there. If there is a treatment stage migration, if there is an untreated progression, but the systemic therapy should be better tolerated and better response in patient with higher or better ALB scores under CTPA. Now, therefore, but this has certain gap. Now, resection, as I told, was a very important treatment in Southeast Asia because we don't have organs to transplant. These patients have good liver function. Now, Western countries define if you have portal hypertension or bad MELD or bilirubin is high, right, then you don't resect it. But Southeast Asian countries were very aggressive. They could resect it. And now with multimodality treatment, they can downstage and resect it when organ is not available. Remember, 5-year survival following resection is 75%. So that is what one thing it is not there, which INSL thought should include. And since we have live-related liver transplant, and 10% of the total transplant, targetable transplant patient get live-related liver transplant. 90% don't get because of cost, because of organ availability. So resection is a good treatment option in our country. And second thing, now the treatment in our country is available widely in all tertiary care centers, and particularly starting from locoregional therapy, including intra-arterial therapy and ablation therapy, right, radiotherapy. All these things are available. This multimodality treatment to downstage has not been suggested. And they have blindly removed any portal vein invasion. Now, a branch of portal vein also is not amenable for surgery, right? That is contraindicated because portal vein invasion, according to them, is a biological aggressiveness. But on the other hand, the experience in other places has shown, even though the portal vein, branches of portal vein are involved, they can be treated, they can be cleared using radiotherapy. There are various forms of radiotherapy that can be cleared. And they can be even from, in this country, the publication is there, even the main portal vein invasion, which has been eradicated with TARE and SBRT, has been subjected to transplant. So that is the ambit, that is the variation. Accordingly, we have to guide this. So role of TARE, SBRT, except barring large tumor that is more than 8 centimeter, BCLC doesn't give much emphasis. And when the child's function is bad, that is liver function is bad, that is decompensated, but the tumor is small, they do not suggest transplant. And that's another area where they can be transplanted. And the results are excellent. It is being done. And publication from this country shows that. I have given you the criteria for resection. I did not go into this, right? This is the Hong Kong liver cancer staging group where I was trying to say, where they say good liver function patients. These are good liver function patients. They don't have vascular involvement, they all resect. This is what I want to emphasize. So, more aggressive treatment can be given. And they have shown using this HKLC in comparison to BCLC, their 5-year survival is much better. Right. This is APSL. Has sought, APSL has also followed the resection. Here they have emphasized. Similar to HKLC. And they have increased the ablation to larger tumors. And multimodality treatment has been emphasized. And of course, performance status is an important consideration which they have considered. Now, what we did, depending upon all this background knowledge, we have kept early HCC, that is 0 to A, as I suggested. That is BCLC 0 is less than 2 centimeter. BCLC A is same. But we have stratified A into two groups, A1 and A2. A2 is a single tumor, more than 2 centimeter. And A1 is single tumor more than 2 centimeter. A2 is tumor burden is more, but less than 3. They have similar transplant, resection, ablation. The intermediate HCC, which was BCLC-B, which was divided into 3 groups, as I remember, where the performance status was 0. That means he could do all his work. He doesn't feel tired, right? We have increased the ambit to performance status up to 1. And CTP, we have included up to 8, right? So we have increased because many of these patients can be treated with their etiology. They conservatively, you can increase their albumin, increase their liver status, and subject them to treatment for aiming for cure or more effective palliation. Advanced HCC, BCLC-C, we have divided into C1 when this is above the second order of portal vein. This is the second order of portal vein. This is the right or left portal vein, BP3. BP4 is main portal vein. So that is if the vascular invasion is there, divided into C1 and C2. And if there is extrahepatic spread, C1. But this doesn't limit the treatment according to us. Remember, oligometastasis in liver cancer is not a contraindication for aggressive therapy. Oligometastasis can be treated. It's one tumor. And lungs or bone, you can subject them to radiotherapy, you can ablate them, you can resect them, and treat the tumor with multimodality treatment. That is what we have done. B1, as suggested in BCLC, we have suggested upfront transplant. That is, it is beyond Velan. That is tumor more than 3 or largest size less than 3. UCSF is tumor up to 6.5 single tumor. In Velan's single tumor up to 5 centimeter. Or largest tumor is 4.5 or total tumor diameter is 8, which is little more than Velan's. You can subject them to transplant because 5-year survival rate is similar. If it is beyond UCSF, people are doing surgery with excellent result. So INASL has recommended you can downstage them. However, when you are downstaging and transplant, the biological aggressiveness of the tumor is very important for post-operative recurrence, for post-transplant recurrence. And there, alpha-fetoprotein has been used recently as one of the indicators not to transplant with more than 1,000. They don't. It has to be less than 100. These are tricky variation which has been incorporated into this staging and discussion, right? And you can resect if he fulfills the resection criteria. If it is beyond the extended criteria for transplant, he have a good arterial feeder, preserve portal blood flow, then you can give intra-arterial locoregional therapy, right? TARE we think is better than TAS. That's why we have recommended transarterial radioembolization over transarterial chemoembolization. And you can also combine intra-arterial radiotherapy in one lobe, another lobe you can ablate. So taking the tumor burden, taking the vascular invasion, and providing excellent palliation. As I told, B1 and B2, resection is also an option which we have discussed. And if there is a B3 and C1, that B3 is a diffuse one, which doesn't respond to TAS. And C1, if the vascular invasion there, tear is better. That has been already, there are results. If you have MAGE portal vein is patent and secondary branches are involved, you can also use multimodality treatment to subject them to resection. And I suggested some people are doing transplant. And if there is treatment stage migration or untreated progression, you go to systemic chemotherapy. So this is INASL recommendation, right? So what we have done, we have divided into very good liver, very good functional status. You have cancer. Second is, you have an intermediate liver function, CTB less than 8, but functional status is very good. And third is, the CTB is 8, is not A, CTB is B, and functional status is intermediate. And fourth is bad liver with bad liver functional status, either of them. This is the basic division to increase the ambit of treatment. And good liver is similar to BCLC, 0 or A. And they are offered curative option. Intermediate liver, as I told, intermediate stage B, which is discussed, B1, B2, B3, right, where we have included downstage, we have included multimodality, and diffuse one, which was suggested to have a systemic chemotherapy in BCLCB, we have suggested transarterial radioembolization because of that. That's the modification. And if you have functional status intermediate and portal vein invasion without any other extrahepatic state, again tear or SBRT, we have increased use of radioembolization and SBRT, right? In this so-called
Dr. Acharya, can we conclude?
This is last. Right. And if you have extrahepatic period, we have suggested systemic chemotherapy. And terminal stage D, if a small tumor within Milan's, we should suggest liver transplant. However, it is tumor beyond transplant criteria or functional status is very good, obviously it is very unlikely they will respond to any form of therapy. This is what we have done. But another thing I have suggested, affordability and donor availability. Therefore, resection is more important, which I earlier emphasized. And you can also, in earlier stage of BCLCB, you can resect one and offer treatment to others. This we can do, and we have it. That's why I have suggested it. So, in summary, what we have staged, that is advanced local therapy to take care of intrahepatic vascular lesions. We have not excluded intrahepatic vascular lesion. We have also not excluded large tumor burdens. We can downstage it and subject them to curative therapy. Systemic chemotherapy in combination or sequential therapy, which I didn't discuss, somebody else will discuss, in advanced and intermediate HCC has been also included in INASL staging and allocation. Using the therapeutic potential of HCC staging is further subcategorized, as I suggested, to deliver more personalized treatment, either to cure or provide long-term effective palliation. However, these treatments can be delivered to person with larger tumor burden, even with vascular invasion, in patient with good liver, good performance status, and absence of extrahepatic state. What we are trying to say, the patient are being more individualized treatment. We have tried to homogenize that. We have tried to combine treatment in advanced tumor and bring them down and provide them curative. And therefore, this staging looks complicated, but once you use it, it will be simpler. Thank you.
Thank you, Dr. Acharya, for the detailed discussion on the BCLC stage and the management strategies. This is very clear that if the tumor is small, you do the resection or the transplant. But only thing is that many patients may not fit into that. But in our country, the things are different because we are doing the live related transplants. So we can send these patients for the transplant. More and more cases are being transplanted now. Yeah.
I think we should also, if our transplant team members are there, Dr. Kaman is there, and the other members also. So if they have any counter view, any view on down staging and then sending the patient for transplant, or they completely agree with what has been discussed and what is in the guideline, Indian guideline. Because so far we have been listening to only gastroenterologist and hepatologist view. Any view?
Yeah, in the later part of the evening, I'll be speaking on the role of liver resection versus liver transplantations. I'll be speaking on that particularly, how to downstage and what is the role of transplant in the situation. But what Dr. Acharya has mentioned and discussed, definitely that is the standard of care at present, definitely. Previously we are selecting our patient depending on the Milan's or UCSF criteria. But now there are lots of extended criteria because the UCSF and Milan was mainly depending on the morphology of the tumor, the number, then the size. But nowadays more biological marker, as Dr. Ashish has mentioned, like including the alpha beta protein, So we are moving away from the morphology to, I think, biology. So that makes sense.
The biological aggressiveness of tumor, as surgeons, you people say, is not only alpha beta protein. It is also PET scan.
Oh yeah, the tumor grade also.
Histology.
Tumor
it's
grade
also vascular invasion. And after downstaging, the waiting time. So you wait for 3 to 6 months. If there is a recurrence, obviously that is aggressive tumor, and post-transplant recurrence rate will be higher.
Definitely.
So these are 5 or 6 basic biological aggressive markers.
Definitely, I agree with that fully.
Each of them needs further discussion. Right. Now, essentially, what I want to convey, this will further change. Because now you are using chemotherapy, systemic chemotherapy, combination of essentially multikinase inhibitor, anti-angiogenic inhibitor, and immunotherapy. Right. You are combining this now. Say etijobivas is become the standard first line. Durvalumab and trevilumab is also Himalayat has been cleared by FDA. There is ipilimumab, which is not working very well, but that will come. There are many other oral chemotherapy, Linva, sorafenib, lenvatinib, regorafenib, carbogenetib, right? There is a series of oral multikinase inhibitors, which is in other cancers as well. Now, these combination therapies are also being tried. And in coming 10 years, I suspect the whole ball game will change.
And definitely, cancer is a systemic disease. Like surgery and transplant is a kind of locoregional treatment. So you have to treat a systemic disease with a systemic therapy. That is the whole basis of being a kind of neoadjuvant chemoradiotherapy in other solid tumor. Like most of our understanding for solid tumor in a neoadjuvant setting has come from most probably cancer breast. And those has been extrapolated to treatment for other solid cancer, including HCC. That is the basis of downstaging thing. And you do the licoregional treatment, including surgery.
But doctor, we have an advantage. We have an advantage. We have an advantage of transplant because underlying disease, liver is disease. The fellow can die, unlike lung cancer or pancreatic
when
cancer.
we are dealing with HCC, we are dealing with two pathologies. So it is not a single pathology. Number one is that HCC itself and the disease liver, that is a cirrhotic liver. In fact, the beauty of transplant is you are treating like on a two situation with one treatment modality. That is the beauty.
That's right.
Yeah.
Thank you.
Thank you.
We can take one more question.
Good evening, sir. Nice presentation, sir. Myself, Dr. Kaptan Singh, sir. I'm working as a SPB and liver transplant surgeon at Max Hospital, Mohali. My question to you will be regarding the intermediate and the advanced stage. As you mentioned, the treatment for very early and the early stage is very much defined. But for the intermediate and advanced stage, when the tumor progresses to the vascular invasion, like VP1, VP2, we can take up directly for the transplant. But what about the VP3 and VP4, where we are subjecting downstaging and then followed by the response to the treatment, and that's in the form of mainly in the PET scan. And after downstaging the tumor, we wait for at least 6 to 12 weeks for the progression of the disease and the clinical condition of the patient. So, are you aware of any prognostic model like in the form of FDG avidity? If the tumor doesn't show any FDG avidity post downstaging, that's included as one of the prognostic marker. So, are there any other things like this which are available right now?
I told you the 5 things, no? One is alpha beta protein. When you are downstaging, your alpha beta protein should come down. And if it is less than 100, chances of recurrence is less. Number 1. Now, if you have a PET avid tumor, after downstaging, PET avidity is also important. Now, many studies have used histology because previous care, that's needle track seedling, is actually not very valid. There are many studies now. Because poorly differentiated liver cancer is another biological aggressiveness than well differentiated. Third thing is vascular invasion per se is there, right? There is no doubt about it. And I think these are usual tumor marker and waiting period what you follow. Because if you wait, if they recurs. So these are combination of factors. You have to use these combined factors depending upon an individual patients. Now, one patient has a very high alpha beta. Another patient had a BP2 embolize, but alpha beta protein is not high, right? Another patient has multiple satellite nodes. Another patient has a PET positivity. They're aggressive, right? But stratification of each of these markers, as far as their aggressive is now concerned, except alpha beta protein, has not been defined.
Thank you, sir.
Dr. Kumar took a very broad view that this is a systemic disease and it requires systemic treatment and systemic chemotherapy. Any view from our oncologist, Dr. Gaurav?
It's true, sir. Cancer is a systemic disease. The problem is, I will agree with Dr. Acharya that liver is the only organ which we have luxury of replacing. So I think if surgeons agree, then resecting a tumor, possible permitting the liver function, can be the best foot forward.
The surgical resection gives you time. 5-year survival of surgery is 75%. I agree, 2 years recurrence rate is of 50 to 70%. Right? Because by the time you have detected 1 or 2 or 3 tumors, there are multiple mutations inside the liver. So the recurrence rate will be high. But that gives you a time for patient to organize in our country, logistics, to get a transplant. Right. So salvage transplant in patients with resection is always feasible. That's why individualized treatment. But personally now you will agree and all of you agree, now liver tumor treatment should be multimodalities. We need a radiologist, interventional radiologist, diagnostic radiologist, need an oncologist, need a hepatologist, need a transplant surgeon, need a critical care expert. And there should be a tumor board which decides on an individual patient, keeping this basic information of literature of staging, allocation, and prognosis in the background. Because in clinical practice, you cannot actually fit in every patient into stratified stages. A fellow who is child, say, had BCLCA, has a diabetes, he is obese, in comparison to a thin fellow, right, who has hepatitis B induced liver cancer. They are different. You can treat hepatitis B, but it's very difficult to treat a cirrhotic liver because of fatty liver disease. Hepatitis B or hepatitis C can reverse, but those very difficult to reverse. So this has to be by a tumor board and individual stratification, keeping this fact in the background.
Sir, I expect that the guidelines will also mention the importance of tumor board in management of HCC. In most of the centers, because of lack of availability of various specialists which are involved, mostly it is a unit-based and individualistic decision
No, it
making.
should not be individualist.
So I think as a society, it has to be promoted. I would say that the role of a tumor board is very, very essential, especially for this kind of tumor which is multifaceted.
I think we have suggested in that.
Yeah, in the latest guidelines, we have suggested that
We have
the
suggested.
treatment of HCC should be multi-modality based on the discussions with the tumor board.
For the first slide I have given holistic management.
I think all of us would be having a lot of questions in our mind, and we have a tea break coming up. So the questions can be put forth to Dr. Acharya in that time. Thank you very much, and a big applause for Dr. Acharya, please.
Thank you, Speaker and Chairpersons. We'll now have a short tea break of 10 minutes and we'll be back for the next session. I request all delegates to be back in the hall by 10 minutes. Thank you.
न्यूमेरिकल नहीं है, न्यूमेरिकल कवर कर ले। अबे सबको नहीं देना है, सबको नहीं देना है। जहाँ पे बंदा बैठेगा वहीं देना। यहाँ पे एक तरफ जहाँ ये कितना है? ये लास्ट है तो इसको लास्ट में रहने दे। इधर वाला का ये बना। ये कौन सा है? लास्ट से पहले वाला है ये तरफ। ये कौन सा है? तीसरा है ना? इसको चेक कर कौन सा है ये? इधर का शुरू का ही है, शुरू वाला है। अभी ये दिखा रहा है।
Welcome back, delegates. For the lack of time, we'll now be switching from session 4 to session 6. For session 6 on systemic therapy and SBRT for HCC, I would now like to invite the chairpersons, Dr. Atul Sachdev, Senior Director, Gastroenterology and Hepatology at Max Super Specialty Care Hospital, Mohali, Dr. Ashish Kumar, Professor, Department of Gastroenterology at Sir Gangaram Hospital, New Delhi, Dr. Madhumita Prem Kumar, Associate Professor, Department of Hepatology, PGI, Chandigarh, Dr. Gaurav Prakash, Professor, Department of Medical Oncology and Radiotherapy at PGI, Chandigarh, Dr. Mohit Nanda, Consultant Gastroenterology, Jalandhar.
Well, thank you very much let me thank Ajay and his team for giving me this opportunity to be here for this academic program. I don't need to introduce Dr. Amit Singhal. I think he's already been introduced and we all know about him. He's a stalwart. And of course, the second talk to be delivered by him is on systemic therapy for HCC. And he's going to talk about the ASLD 23 concepts. Dr. Amit, please.
Thank you. So I'll be speaking about systemic therapy and SBRT for HCC. So two different aspects that I'll try to cover in the next 15, 20 minutes. So here you can see my disclosures. So I think we heard a nice comment coming into my talk, and I think it sets it up nicely. HCC is a systemic disease, and so we always have to think through systemic treatments when applicable. And it's been a truly exciting time when we think of the systemic therapy landscape for unresectable HCC. So here you can see a figure from the AASLD guidelines where we really show, once again, all of the progress that we've made over the last 15 years. We've gone from having a single agent, as many of you know, sorafenib, came around in 2007 and was the only agent that we had for a decade. And then we saw an explosion of therapies, both in the first line and second line space, with other tyrosine kinase inhibitors and targeted therapies coming to market. Lenvatinib in the first line setting, regorafenib, cabozantinib, ramucirumab in the second line setting. And most recently, we've had notable advances with the advent of immunotherapy in the first line space, both the combination of atezo-bev as well as now durvalumab, both showing significant improved survival compared to sorafenib in the first line setting. And these now are our two preferred first line options for HCC. So as many of you know, our entry into immunotherapy was not smooth for HCC. We started with Checkmate 040 showing durable, prolonged responses in about 15% of patients, something that we hadn't seen before, and we were excited. Checkmate 459, the randomized trial of nivolumab versus sorafenib, failed to show a significant benefit compared to sorafenib. And I think this is truly now consistently shown for single agent PD-1, PD-L1 inhibition to show non-inferiority compared to sorafenib, but consistently not showing superiority when used as monotherapy. Now, there's mechanistic rationale for us using combination therapies to improve responses as well as improve progression-free survival and overall survival. Our understanding of VEGF inhibition, most notably, has changed. This is not simply a cytostatic or cytotoxic sort of agent. This essentially is an immunomodulatory agent, which can change the immune system and thereby augment PD-L1 activity. So we see with VEGF inhibition, you increase cytotoxic T lymphocytes by keeping them active. You increase dendritic cell proliferation and maturation. You decrease tumor-associated macrophages, and you decrease myeloid-derived suppressor cells, thereby augmenting immune activity, thereby increasing the effectiveness of a single agent PD-L1 when used together in combination. Likewise, we understand that CTLA-4, another immune checkpoint, can be additive when used in combination with PD-1, PD-L1 suppression. So we know that CTLA-4 acts earlier in the immune system. It thereby can increase your T cell repertoire, increase your memory T cells, and once again be synergistic with PD-L1 inhibition by using the two in combination. So we've now gone from single agent to 2 doublets in the first line setting. So I will say, as many of you know, HCC has been a disease that we unfortunately have not biopsied as much as we should, and I'd argue it's a disease that we remain in the dark. So we see very beautiful preclinical rationale that we talk about for many months to years, and then when it comes to the clinical trial data, that may or may not support it. So I've stopped actually judging a trial or sort of guessing if a trial is going to be positive or negative until we see the data. Because I think we don't really know much about HCC to really guess what will happen with these clinical trial data. And so here, let's take a look and see if those preclinical rationale, the mechanistic rationale, actually translates into clinical benefit. So these are data that you probably have seen now, the IMbrave 150 data, the atezo-bev versus sorafenib in the frontline setting. And atezo-bev significantly improves both progression-free survival and overall survival compared to sorafenib, a median survival of 19.2 months in the follow-up data published in the Journal of Hepatology last year. Hazard ratio 0.66, so a 34% reduction in overall survival. We see responses in 30% of patients, and we see disease control in 74% of patients. And these responses are durable. So the median duration of response, 18 months. So this is a highly potent combination that significantly improves survival now beyond 1.5 years for these patients with advanced stage HCC. Also, atezo-bev is a very well-tolerated regimen. And so you can see here the all grade AEs as well as the grade 3-4 AEs. And you can see here that outside of hypertension, very few grade 3-4 AEs in those patients undergoing atezo-bev, very well tolerated. Now, one of the concerns going into the trial, and of course, when anyone talks about bevacizumab, Avastin, everyone thinks about GI bleeding. And I can tell you every time that I've talked to many of you in the room, and we talk about atezo-bev, one of the questions is, so how bad's the GI bleeding? How often do you see the GI bleeding? And honestly, if you well select patients, the GI bleeding is tolerable and acceptable. It happens in a small fraction of patients. However, you have to think about how you implement atezo-bev. So everyone coming into the IMbrave 150 study underwent an upper endoscopy within 6 months. Those patients who had high-risk varices were treated according to the local gastroenterologist or were excluded. So depending on the sort of high-grade nature or the high-risk nature. So for example, patients with a variceal bleed history were excluded from the trial. But if you had if you had large varices, you could be treated adequately coming into the trial and thereby included into the IMbrave 150. And those patients, once again, as you can see, did quite well with only a small number of patients, 5 patients in the entire trial in the atezo-bev arm having a variceal bleed. Now, the other thing is we now have had atezo-bev on market for a couple of years, and we've now started to see clinical data coming out in real world practice, right? So one of the things you can say is, well, that was a clinical trial. That may or may not apply to the patients I see in my practice. But we see here effectiveness data coming from the AB-REAL study, so multinational, multi-center study, including centers from Europe, Asia, and North America. And you can see here 296 patients. Over a median follow-up, you can see the median survival for the AB-REAL study, 15.7 months. So not significantly different than that of the clinical trial. And when you take a look at patient characteristics, it's not surprising you see a small decrement in survival given differences in patient characteristics, but overall, very good survival in clinical practice. When you take a look at the treatment-related AEs, once again, grade 3-4 treatment-related AEs, 23%. Bleeding events, 8%. very acceptable, small proportion of patients having grade 3, 4 AEs or bleeding AEs. Now, we've also seen data coming from India, and so this is a study that just is being published now, where we can see here a retrospective cohort study of 67 patients treated with atezo-bev in India. We've already heard about the epidemiology, and the majority of these patients in this study were NAFL etiology, 75% BCLC stage C. So when you take a look overall, the median survival 12 months, median progression-free survival 8 months. Objective responses 40%. So very good data. Now, when you say median survival 12 months, that's clearly different than what was seen in the IMbrave 150 study. But take a look at the distribution of Child-Pugh A, B, and C classes. And you can see here that there's a high proportion of patients who had Child-Pugh B or C. In those patients who had Child-Pugh A disease, reflecting the patients that would be in the IMbrave 150 study, you see a median survival of 21 months. Once again, highlighting that this can be an effective therapy in clinical practice, including in patients seen here in India. Grade 3, 4 AEs observed in 20% of patients, 12% of patients with Child-Pugh A disease. So if you have good liver function, good tolerability, good effectiveness. There were only 2 GI bleeds, one with a history of variceal bleed, who once again would be known to have a high risk of repeat bleeding, and the other with VP4 tumor thrombus, which once again, even in the IMbrave 150 study, was a risk factor for variceal bleeding. So if you're looking for risk factors here for variceal bleeding, VP4 can be a risk factor that would make you a little bit more at risk in terms of variceal bleeding on the atezo-bev regimen. Now moving over to the other regimen, durvalumab and tremelimumab. This is a combination of a PD-L1 inhibitor and a CTLA-4 inhibitor. So one of the first therapies that moves away from the VEGF backbone, using 2 immune checkpoint inhibitors. The tremelimumab, the CTLA-4 inhibitor, is given once as a single dose upfront priming, and thereby durvalumab continued after this. This is different than what was evaluated with ipi-nivo, because with ipi-nivo, the ipi was given repeatedly. Here, the tremelimumab is only given once. We see here in the Himalaya trial, the STRIDE regimen, single dose tremi, with repeated doses of durvalumab after, significantly improved survival compared to sorafenib in the frontline setting. So you see a median survival, 16.4 months versus 13.8 months, a 22% reduction in mortality. Now, one of the things about the Himalaya trial is that it had a pre-specified endpoint taking a look at survival at the 36-month landmark. 30% of patients in the STRIDE arm were alive at 3 years. Once again, this is how much our systemic therapies have improved. We're not talking about 1-year survival anymore. Now we're starting to really look at 3-year survival with these regimens. This is how far we've come in a short period of time. STRIDE, very well tolerated, so acceptable AE profile in the Himalaya trial. Grade 3, 4 AEs, 25%. Treatment-related AE leading to discontinuation, 8%. AEs leading to death, 3%, 2.5%. So once again, very well tolerated. So here you can see a figure from the AASLD guidance, and this is how we've put this together in terms of our recommended approach to patients who are being considered for systemic therapy. Patients with advanced stage HCC as well as intermediate stage HCC who are TACE ineligible or fail TACE. The first and most important question you have to ask, is there a contraindication for immunotherapy? Severe autoimmune disease or history of liver transplantation or any other transplantation? If the question is no, that patient should be considered for an immunotherapy-based regimen. If that patient has a contraindication for immunotherapy, that patient can then be treated with sorafenib or lenvatinib. So if you're considering an immunotherapy-based regimen, your 2 choices are atezo-bev or durva-tremi. And the next question you ask yourself is, what is the risk of GI bleeding? If that patient has a low risk of GI bleeding, the recommendation was atezo-bev in the frontline setting. If that patient is at high risk of GI bleeding, varices, portal hypertensive gastropathy, etc., then that patient should be considered for durvalumab and tremelimumab. You can see here that there are also therapies that we have available in the second-line setting, as you know, regorafenib, cabozantinib, ramucirumab. These regimens have been around, and so I'm not going to go through them in detail. One of the controversies that we have when we think about immune checkpoint inhibitors is how does liver disease etiology impact this? I think all of us have seen or heard about the Nature data coming from Matthias's group and Joseph's group showing preclinical data suggesting T-cell exhaustion in the setting of non-viral etiologies, most notably NAFLD, and data that suggests that patients with NAFLD may not respond as well to immune-based regimens. Here you can see more recent data that addresses this controversy. So the first is when you take a look, we can see the responses with immunotherapy don't actually change based off of viral etiology versus non-viral etiology. The second is that we can see on the right-hand side of your slide an updated analysis of how immune checkpoint inhibitors do compared to sorafenib across these different trials stratified by liver disease etiology, hepatitis B, hepatitis C, and non-viral liver disease. And you can see in these different subgroups, as we know, immunotherapy has a benefit in hepatitis B and hepatitis C. And when you include the more recent data coming out for immunotherapy, as the data have matured, you can see here now that there is there is a benefit to immunotherapy in non-viral liver disease. So there is a consistent benefit across liver disease etiologies, favoring immunotherapy over the control arm. And so I think we can say with good confidence that etiology should not impact immunotherapy choice right now. We should not say that we should use TKIs in non-viral liver disease over immunotherapy. This is not a deciding factor in isolation. Now, for the last couple of minutes of my talk, I want to talk about the fact that these have been such notable advances. We're now moving these into earlier stages of disease. So we saw recent data from the IMbrave 050 trial looking at adjuvant atezobev after high-risk resection or ablation. High risk in this study was defined by different factors, including multifocality, degree of tumor differentiation, so poor differentiation, could be size, and it could be microvascular invasion or macrovascular invasion, including VP1, VP2, which we've already heard about being done in some centers. And here we can see that the recurrence-free survival was significantly better with atezobev compared with active surveillance. So when you take a look at the landmark of 12 months, you can see here 12-month recurrence-free survival, 78% versus 65%. So this is a notable landmark because in this study, atezobev was recommended for 12 months after the high-risk resection or ablation, and so you can see a significant benefit there. You do see median follow-up at this first interim analysis of 17 months, and so there's a lot of censoring that happens sort of right before that 17 months as well as after 17 months. And so right now we can say there is a significant improvement in recurrence-free survival, although we are awaiting further maturation of these data to see how long that benefit persists over time. The other thing that we've already heard about is that systemic therapy may be preferred in some patients with large intrahepatic disease, these TACE unsuitable patients. I think this was a propensity matched analysis comparing systemic therapy versus chemoembolization in these patients with tumor with intermediate stage beyond up to 7. And we can see here patients treated with upfront systemic therapy had significantly better survival than those patients treated with upfront chemoembolization. And this was really related to preservation of their liver function in this study as determined by the LV score. You see the LV score being preserved in those patients who are treated with upfront systemic therapy compared to those patients treated with TACE, where there's degradation of the LV score, arguing that these patients probably had converted from Child-Pugh A to Child-Pugh B, thereby limiting what subsequent therapies they could receive. There are now trials ongoing to evaluate systemic therapy in a randomized manner. So this was that prior study was propensity matched, still has some potentials for residual confounding. And here you can see one such randomized trial comparing atezobev versus local regional therapy in those patients with intermediate stage disease beyond Milan. This trial is now enrolling, so we should hopefully have data over the next couple of years in terms of seeing exactly what is the benefit of systemic therapy up front in these patients with large intrahepatic disease. Now, I know there's a lot of interest in combination therapies. We've seen negative trials of combination TKI versus when combined with local regional therapy. There is rationale for using immunotherapy in combination with local therapies, whether that's SBRT, radioembolization, chemoembolization, etc. You can see enhanced antigen presentation, and so you may actually increase IO effect in that way by this release of neoantigens. And also, we can see by the VEGF blockade, you may have enhanced antigen presentation, once again, enhancing this immune checkpoint inhibitor effect. Once again, good preclinical rationale, lots of studies ongoing. We'll have to see what those combination studies reveal over the next couple years. I think this is early. We do not personally use this, and this was not recommended in the AASLD guidance, but was something that is of note to watch as we see these data mature. Now moving on to the SBRT, which was the other thing that I was asked to speak about. Sort of a couple slides talking about SBRT. I will say that we do use SBRT in our center. We have seen very good effects in well-selected patients with external beam radiation therapy. Here you can see one such older study published in JCO in 2016, which looks at the proportion of patients having local tumor control with early stage HCC. This was a propensity weighted analysis. And you can see here that the local tumor control is much better with SBRT compared to local ablation. So you take a look at factors associated with local progression, and RFA had nearly a four times increased hazards of progression compared to SBRT. When you take a look at subgroup analyses, this was really marked in patients whose tumors were greater than 2 centimeters, which we know is associated with decreased complete responses with local ablation. And so once again, in our center, if somebody is not amenable to local ablation because of location, or the tumor size is greater than 2 centimeters, we use SBRT in many of those patients. I will say, this is a recent study published in Hepatology Communications. We did participate as one of the sites in this multi-center study. And I have to say that this at least gives us some pause, and we're sort of currently reassessing sort of how aggressively we use SBRT in some patients. So this was a propensity weighted analysis comparing SBRT and ablation among 642 patients. 440 who underwent ablation, 202 that underwent SBRT. Once again, consistent with the data that exists, we see better local tumor control in those patients who underwent SBRT, and you can see that on the left-hand side of your slide. So significantly better, so you see a 70% reduction in tumor progression with SBRT compared to ablation. However, there was a significantly higher proportion of patients that had an increase in their Child-Pugh score after SBRT as compared to ablation. So the proportion of patients that had liver dysfunction after SBRT was higher. And unfortunately, sort of much to our surprise, we saw a higher hazards of death after SBRT compared to ablation with a hazard ratio of 2.0. And so this liver dysfunction may preclude you from receiving subsequent therapies. And so once again, it is something that we are assessing. We do continue to use this as a bridging therapy for liver transplantation, because there you have a destination, and so this risk of liver dysfunction longer term may be less notable, but it is something that we're reassessing in non-transplant patients, at least at our center. The other thing that I think is interesting, once again going back to this combination therapy, is the fact that you may be able to combine external beam radiation therapy with immunotherapy. So this is one single study that I could find, 21 patients combining radiation therapy in combination with atezo-bev. This was done in patients with different stages of disease, although the majority of them had advanced stage HCC. So you can see 67% Child-Pugh A, 80% VCLC stage C. And the radiation therapy was really given intensity modulated radiation therapy, so median 60 gray given over 15 fractions. 13 patients had it concurrently, 5 neoadjuvant and 3 adjuvant. You can see here the median survival from the start of RT was 6.8 months, median progression-free survival 3.6 months. However, it should be once again noted that 57% of patients had a worsening of their Child-Pugh score of 2 or greater, with a median of 9 months to worsening. Unclear if this is related to tumor progression or if this was in part related to some of the radiation therapy. But I think once again, as we think through combination therapies, I think we have to understand that you may increase efficacy and responses, but we also have to think of the converse when we think through toxicity, most notably liver dysfunction, that we're not sort of getting into trouble where we're then sort of limiting subsequent lines of therapy. As we've heard, this is not a disease that should be treated unilaterally. The AASLD guidelines have a specific section and a specific strong recommendation to recommend multidisciplinary care for all patients with HCC, and we said it should be considered standard of care. I would argue that this is a disease that should be treated in large centers or centers that have established collaborations where these patients are routinely discussed as a group. We know from several studies that multidisciplinary care is associated with improved clinical outcomes. So you can see here 12 studies, 15,000 patients. This is associated with increases in receipt of curative therapy, increases in guideline concordant therapy, and most notably, a 37% reduction in the risk of death. And so once again, should be considered standard of care. In summary, we have very effective therapies now. These combinations should be considered the preferred therapies in the first-line setting, atezo-bev and durvalumab for systemic therapies in unresectable HCC. Systemic therapies are now proven in the adjuvant setting with the recent study that I talked about, and are being evaluated both alone as well as in combination with local regional therapies in the intermediate stage setting. I would also argue that we need to become increasingly cognizant of taste failure and taste unsuitability, so those patients are started on systemic therapy in a timely manner. We know that SBRT as a potent therapy can induce high rates of local tumor responses, high rates of local tumor control. I do think that we need to think through the potential for radiation-induced liver injury, and ongoing studies are also evaluating this in combination with systemic therapy. And finally, as I just mentioned, several studies highlight the benefit of multidisciplinary care for management of HCC patients, and this should be considered standard of care if we want to optimize these outcomes. Thank you so much. Happy to take any questions.
No. I think Madhumita has been very actively listening to all this, and I guess she's been analyzing your data. Madhumita?
I think that's an excellent point. Thank you for coming here and at least telling us about the guidelines and the updated data analysis that's available. 2 points from an Indian perspective. Most of the time when the patient presents to us, they're already child B, C, So the eligibility for the students in the room is if they're child A or maybe child B1. So that's the most important point. The patient should be stable enough, should not have advanced portal hypertension, so they will not only be eligible for these trials then. Then the second point is the prohibitive cost. So at current costs that are available, which are non-generic because it's still under patent laws, it's not really cost effective for a survival advantage of 3 or 4 months. We just looked at the real world data that you presented for the STRIDE study. So over sorafenib, there was just a survival benefit of 3.5 months. So for that additional cost, how do we justify in our patient setting?
I'll take the first question from the Child-Pugh A versus B status. Child-Pugh C, I'll sort of do separately, but Child-Pugh B, I would argue first that we have to recognize that Child-Pugh B is not a Child-Pugh B. So even within that group, there's marked heterogeneity. So like a B7 is very different than a Child-Pugh score of 8. It's different from a Child-Pugh score of 9. And how you get to that Child-Pugh, whether that's ascites or encephalopathy or lab abnormalities, also matters. And so I think that we have to understand that there's heterogeneity in that Child-Pugh B group. We are, to your point, the clinical trials all included patients with Child-Pugh A. And this is where the real world data will help us really understand how these therapies perform, both from a potency and response perspective, as well as from a safety perspective. You've seen some of the real world data for atezo-bev already. And there's a paper that we're just finalizing and in the process of submitting multi-center study coming out of the AB Real study, now taking a look at atezo-bev in patients with Child-Pugh and really understanding once again, the survival as well as safety in that Child-Pugh patient population. In well-selected patients, atezo-bev can be safe in a Child-Pugh patient population, and once again can improve survival. In terms of these patients, the company is also doing a prospective study in Child-Pugh patients, so we will have prospective data in terms of capturing, safety and effectiveness in a Child-Pugh patients population. So this is an area where we will have further data. But to your point, I think when we apply this, I think we have to be very careful about selecting patients, making sure, particularly in that patient population, using atezo-bev to do the upper endoscopy, assessing bleeding risk. But in well-selected patients, much like we've seen with TKIs, you can help patients do well. Your second question of cost is something that, of course, we need to be cognizant about. And I understand that immune checkpoint inhibitors are more expensive than TKI-based therapy. I come from the US where I would argue we don't really care about cost as much. For the better or for the worse, I don't know. But I think your point's well taken that we do need to consider cost. And I think it's one of the things when we talk about these therapies, we shouldn't make choices for our patients. I think these are things that we present to our patients. So I think, even if when I say you, like us, feel that these are expensive medications and, we may question, okay, is that worth it or not? I think at the end of the day, that's something that the patient would have to choose. And so from a provider perspective, our job is to understand the effectiveness of these medications, the safety of these medications, and then present that to the patient and say, this is what the cost would be to the patient out of pocket, and ask them what they would like to do. I would argue that the benefit of these therapies extends beyond median survival, right? So it extends beyond median survival. Yes. These are therapies where you can see responses in 20 to 30% of patients. You see, honestly, not just anecdotes, but I have seen multiple patients with widely metastatic disease that have a complete response. And those responses are not seen on TKI therapy. Lenvatinib, I know it induces responses. Those responses are not what you see with immune checkpoint inhibitors. So I think we have to be able to talk about all of these different aspects. Improvements in median survival, improvements in responses, improvements in complete responses, and AE profile. So the quality of life for these patients on immune checkpoint inhibitors has been shown to be significantly better than TKI-based therapy, both from an AE perspective as well as quality of life instruments. So deterioration of quality of life significantly better both with atezo-bev and the stride regimen. And so that's another aspect that I don't know if we can put a price tag on that. Like anyone who's used TKI therapy, we can manage the AEs. But I would argue lenvatinib, even though it doesn't give you hand-foot like sorafenib, the anorexia, the weight loss, the fatigue, those are notable AEs that the patient is living with on a daily basis. And I will tell you, I've seen patients that will say, I will gladly pay thousands of dollars not to have those AEs.
So just to summarize, it's an iceberg disease. The eligibility for atezo-bev and the science clearly shows it's highly efficacious, it's safe, and it can have miraculous complete remissions or, a downstaging effect in those who would not have otherwise be eligible. But the patient should be eligible and the patient should be able to tolerate it, and the cost maybe in the future might come better. So I agree with that point. The second question for you is, which is better for a clinician to use, the progression-free survival or the overall survival?
Overall survival, right? Progression-free survival, if you're looking at both, what do patients care about? They care about how long they're going to live. Progression-free survival can be a surrogate outcome for many cancers. That being said, in HCC, it hasn't been a great surrogate. We've seen trials, Cosmic being one of them, combination of cabozantinib and atezolizumab, improved progression-free survival, no difference in overall survival. We've seen this where these two outcomes can be discordant. And so I think the cabo and atezo is probably the sort of epitome of this. So The trial showed a significant improvement in progression-free survival, no improvement in overall survival, and the company didn't even move forward with filing for it. So I think that shows you not only from a provider perspective, a patient perspective, but even industry understands progression-free survival without overall survival doesn't mean anything.
I have a question. What is the proportion of patients who get complete response with systemic therapy in your experience?
Yeah. So, the complete responses is sort of around that sort of 10% mark. So, I understand, 30% overall responses with atezo-bev, complete responses is a fraction of that, so, closer to that 10% mark. But I would argue those are numbers that we never heard of before. And when you have these are not small tumors. These are patients who have widely metastatic disease to the lungs, and metastatic disease to lymph nodes, et cetera, that you see all of it melt away. And I actually, once again, not to only speak in anecdotes, but we have a patient who had a metastatic disease to a lymph node, was treated with atezo-bev, complete response, patient's disease decompensated. We actually biopsied the lymph node twice to prove to us that it was necrotic, that there was no residual disease. Because he's decompensated, he's currently listed for transplant. That's what we're doing. We're converting people from metastatic disease to curative disease. That's the potency of these medications, not possible with TKIs.
Dr. Amit, keeping time in mind, very quick point. Looking at STRIDE data, looks a very neat design, like, durvalumab with Tremali in combination with sorafenib, which was the erstwhile standard of care. But now, goalposts have moved. We know we have atezolizumab and bev.
Yeah.
So what are your views on the choice of therapy between these two regimens? Because sorafenib is almost now in the back seat.
Yeah.
The second part, if may I, because Tremali is not available in India, so do you think any data on ipilimumab, because we can use for those patients who have high risk of bleeding and bev is out of question? So 2 points which I would like to know.
So, the first point, the Himalaya trial was designed when sorafenib was standard. So, I think it's much like the second line trials where all of them use sorafenib and then, other agents came and you're like, well, now what do we do? So I think, both Himalaya and Embrave 150 were designed when sorafenib was standard of care. And that's why the comparator arm in both of those trials was sorafenib. But it does leave us now in sort of a murky gray zone environment, right? Where we have two good regimens in the frontline setting and we don't have direct comparative data. So there's been network meta-analyses that, you can use to compare these indirectly. Atezo-bev was, better than durva-tremi, although not statistically significant. So when you take a look at this across the clinical trials, atezo-bev had the best sort of outcomes in that network meta-analysis, significantly better than that of sorafenib and significantly better than lenvatinib. However, numerically higher, not significantly better than that for durva-tremi. So still, how do we choose? And I think that's where the AASLD guidance, this assessment of GI bleeding risk, I think it helps us. So it's really BEV eligibility. If you have any concerns about BEV eligibility in terms of bleeding, stroke, cardiovascular disease, proteinuria, then you would say, okay, I want to use a BEV-free regimen. If you don't, I think atezo-bev right now, I would argue, is probably our most potent combination. Understanding we shouldn't do cross-trial comparisons. And I think I say that with a huge, huge grain of salt. But when we have nothing else, that's what we end up doing. So I think that so the BEV eligibility is the way that I decide between right now, STRIDE versus atezo-bev. Your second question of, we don't have Tremi right now, and so, waiting for launch in India, and so what can we do in the meantime? I don't think that this is something that is specific to like Tremi versus IPI. These are all mechanisms of action. I would argue, understand, no data, this would be a lot of extrapolation. One of the beauties of STRIDE is a single priming dose. You take a look at the AEs on the Himalaya trial compared to what we saw in the Checkmate 040 study with Ipi-Nivo. The immune-related AEs, much less in the Himalaya trial. It's a much better tolerated regimen. And so I would argue that if we learn nothing else, I think the sort of single dose, the priming dose is a good way to deliver this. And I think that you could probably extrapolate if you want to try to do something else. Understanding, no approval, et cetera, et cetera.
Agree on that.
Yeah.
I think, Kaptan, we're running short of.
I think
Kaptan,
it's
can I intervene here?
Yes,
I guess we are running late already, and there have been a couple of bells.
What? So thank you, Dr. Singhal, for a masterly talk once again.
You
And
can have
big round of
discussion later.
applause.
Thank you, sir.
Sorry.
Thank you.
Thank you, speakers and chairpersons. We move on to session number 4 now. Ablative and endovascular treatment for HCC, what's new? I would like to invite the chairpersons, Dr. Varun Mehta, Professor, Department of Gastroenterology at DMC Ludhiana, Dr. Nipun Verma, Associate Professor, Department of Hepatology, PGI, Dr. Sridhar, Associate Professor, Department of Radiodiagnosis at PGI, and Dr. Varun Gupta, Consultant Gastroenterologist, Jalandhar.
Now we shift gears from the pharmacological therapy to the radiological management of HCC, and IR has a great role in the management of HCC. I'll have the honor to invite Dr. Naveen Kalra, who's basically done a lot of work on interventional radiology, especially HCC. Will be enlightened by his talk.
Yeah, thank you, sir, and good evening, everyone. At the very outset, I'd like to thank INASL, especially Dr. Ajay and Dr. Sunil for having me here for this meeting. And I'll try my best to cover this topic assigned to me in the allotted time. And it's ablative and endovascular treatment for HCC, what is new. So I'll be, kind of touching it in between what is the established treatment modalities. So in tandem with that, I'll be discussing this. So no financial disclosures here. We all know that surgery is the treatment of choice, but unfortunately, the majority of patients, when they present, are beyond the resection stage. We've heard a lot about the staging system. So the BCLC it shows where the ablation fits in with the very early stage and the early stage disease. The TACE fits into the B2 disease. And those in the early and very early stage disease who are not candidates for ablation, we have the tear technique, and it can be done up to lesions up to 8 centimeters or less than that. So ablative therapies, ablation involves the use of chemicals, thermal or non-thermal energy delivered via electrodes or otherwise directly to the tumor to achieve necrosis. And this is the classification of ablation you can see on the right side. And amongst the newer ones that we have with us are cryoablation and irreversible electroporation. So we all know that RFA is the run-of-the-mill, where the high-frequency alternating current, when it is introduced into the tumor tissue, the ions oscillate and there is frictional heat and there is the ablation occurs. And while doing these thermal ablations, we have to be careful if there is a lesion which is close to the collagenous structures, as in this patient, close to the lesion, close to the diaphragm. So what we have to do is to create artificial ascites, put in 5% dextrose, and then do our ablation. From RFA, we moved on to microwave ablation, which is electromagnetic waves and with frequencies higher than 915 megahertz. And in this, the water molecules, they align to the changing field lines, and the neighboring macromolecules are heated by convection. So when we compare RF and microwave, what was the need for microwave ablation? It results in higher intratumoral temperature, less susceptible to heat sink effect, shorter procedural time, larger ablation zone, and you can use microwave ablation even when the patient has surgical clips or a pacemaker in situ. So here comes in another difficult to treat location. That's a tumor at the hilum of the liver. and it is just abutting the portal vein as well as the hepatic artery. So here it would be, you have to do thermal ablation with caution or resort to another modality. And in this patient, if we just had these two modalities, we would have probably done the TACE for this hilar lesion. So, and that is the reason, this typical location, why we needed another ablation modality, and that is electroporation. So, irreversible electroporation is a non-thermal technique that uses pulsed direct current to induce cell death. There are nanopores which develop in the cell membrane. The cells become leaky and apoptosis occurs. The good point about IRE is that it spares the normal connective tissue network, which means we can framework. So which means we can do these ablations when the lesions are close to the vessels. So it requires high voltage current, multiple pulses are given in stages, and there's a mathematical model to do the IRE. And you have to introduce probes which are parallel to each other with a described minimum and maximum separation between these. So this is another patient where this is go back. This is the hilar lesion that I showed earlier. This is a similar patient, similar location for this HCC which developed in the hilum. So here we have done the anterior approach, putting in multiple parallel oriented probes for the IRE under CT guidance, and procedure is done under general anesthesia. And we need to do ECG synchronization because arrhythmias may occur. So this is required to be done. You have to be accurate and precise in the placement of your IRE probes. And the result is that there is ablation without any significant arterial or venous injury. So this is the publication from our group where we showed the safety of IRE for unresectable HCC in 21 patients. This is again a meta-analysis published by our group which looked at 25 studies in which the safety and efficacy of IRE for malignant liver tumors was assessed, and hepatocellular carcinoma was associated with a better overall survival compared to metastasis and cholangiocarcinoma at 12 months and 36 months. High complication rate you can see here, but if you look at the major complications, they were less than 7%. So this is a technique, another one, the cryoablation, which has been around for a while, but now there's a resurgence of using it because there was a change in the hardware that is used. Early systems had bulky probes and liquid nitrogen was used, but now we have the argon helium superconducting targeted system, and smaller probes have evolved. So this has revolutionized the clinical application of cryoablation. It works on the principle of the Joule-Thomson effect, where there is cooling via rapid expansion of argon and an ice ball forms at the tip of the probe that is introduced into the tumor. And it acts by causing mechanical disruption by the ice crystals that form within the cells and outside the cells, by vasoconstriction, by apoptosis, and by immunomodulation. So the advantages of cryo are you can visualize the ice ball, there is no severe pain, which means you can do the procedure under local anesthesia compared to the other ablative techniques. And there's little impact on the nearby blood vessels, it doesn't affect collagenous tissue, and you have a cryoimmunological response as you have with IRE as well. So this is another patient, again, central lesion as well as a subcapsular lesion in the caudate lobe. You can see on these arterial and venous phase images. And this is how it looks like on ultrasound. And that's the hardware where we can actually plug in up to 8 probes and do the cryoablation therapy. And that's these ultrasound images show the progression of the ice ball as cryoablation is done. And similarly, the left lobe lesion, the progression of the ice ball well seen on ultrasound as the cryoablation is done. And the good thing, as I said earlier, you can visualize the ice ball on the CT as it progresses. So this is another meta-analysis from our PGI group, which looked at the overall survival and local recurrence following RFA, microwave, and cryoablation of very early HCC. Looked at 19 studies, so there was no significant difference in the overall survival and local recurrence at 1 year and 3 years following ablation of very early HCC with RFA, microwave ablation, and cryoablation. And there was no effect of the tumor size on the treatment efficacy. So this table just shows the comparison between the four major ablation techniques: RF, microwave, cryo, and IRE. And you can see IRE is non-thermal, and it requires a longer time to treat. The costs are more, but you can use cryo and IRE for tumors adjacent to critical structures. You need to do general anesthesia for IRE. For the others, you can do under local anesthesia or conscious sedation. So this is the working model that we use at PGI for tumor ablations of the liver. If you have a central lesion close to the hilum, we use IRE. If it's a subcapsular peripheral region, we use cryoablation for lesions close to gallbladder as well. And the intermediate zones, we use microwave and RF. We use microwave when the lesion is close to a vessel because we want to take care of the heat sink effect. So in those situations, we use microwave ablation. So this is another technique which is primarily an extension of HIFU. Now it is kind of a resurgence, is seen though been around since 2004. That is histotripsy. It's a non-invasive, non-thermal, non-ionizing focused ultrasound method to treat cancer. It uses controlled acoustic cavitation bubble cloud generated using focused short duration ultrasound pulses at high negative pressures to mechanically destroy tissues at the cellular level without damaging the intervening tissue. And what we achieve is a precise treatment zone composed of an acellular homogeneous sharply demarcated tissue from the non-target tissue. So how do we compare histotripsy with HIFU? There's higher intensity ultrasound. We have non-thermal ablation by mechanical cavitation. We have pulsed energy compared to HIFU, and we have cellular fractionation with histotripsy. With HIFU, we have coagulative necrosis. So this is the new kid on the block. There is a one human trial, looked at 8 patients as shown on the left side. And in this trial, they found that this was safe, and what we achieved on histotripsy was a very predictable volume that they had thought of pre-procedure. And on the right, you can see that there is a new trial that has started, a non-randomized single-arm prospective European trial, and that's the Hope for Liver trial for looking at this histotripsy in the primary and metastatic liver cancers. So moving now on to the endovascular treatment aspect. So we all know the bland embolization, CTACE, DEPTACE, and the tear, they exist. And for each one of them, you need to go super selectively into the tumor and deliver your embolizing agent. And what is important for doing all these procedures is that you have to identify all the vessels that are feeding the tumor. You also have to look for, in addition to the variant anatomy, the extrahepatic supply, like in this patient was from the IMA. And for that, we have always had the facility of a cone beam CT at our institution, as well as it is the norm to do these procedures with a cone beam CT. But now from cone beam CT, we have now moved on. That's a new advancement, is the hybrid angio CT, where in the same table, you'll have a patient lies on the same table and you have a fluoroscopy unit as well as the CT. And this will help you to look at the vascular anatomy as variant anatomy, as well as the extrahepatic, the supply to the tumors. So studies have been done to compare the cone beam CT versus the catheter CT hepatic angiography, and it has been found that CT-HA is superior to the cone beam hepatic angiography for tumor identification, tumor feeder vessel identification, and also the breathing artifacts are much less if we do a catheter CT hepatic angiography and use the hybrid angio CT versus the other one. So this is an example of a patient with a tiny lesion in the dome of the lesion, not very well appreciated. But if we did the intra-procedural angio CT, and you can see the feeding vessel as well as the blush. So this helps us to reach super selectively into this tumorous vessel and do our TACE therapy. So drug-eluting beads, we know, are polyvinyl alcohol-based microspheres, and they allow simultaneous delivery of uniform embolic and chemotherapeutic agents, allowing fixed dosing and ability to release the anti-cancer agents in a sustained and controlled manner. Requires about 30 minutes to prepare these, load the drug onto these beads. and usually indicated for large size tumors more than 6 centimeters in size, and especially those tumors in which we can identify a single vessel feeding them. And as you can see, it results in complete necrosis once we've used drug-eluting beads. The results of drug-eluting beads, as far as tumor response rates are concerned, the precision trial showed that depth TACE was better than conventional TACE, and time to progression was better with depth TACE rather than TACE. And the adverse events were also much more with C-TACE vis-a-vis the drug-eluting beads TACE. But a recent study from the Japanese group, where they've compared the TACE and the depth TACE, they found that the complete response at 1 month and 3 months was more with the conventional TACE. And though the post-embolization syndrome, that was more with conventional TACE, and that was expected. And the hypothesis they give for these results are that if you use conventional TACE, the particles get pushed beyond the sinusoids into the portal veins radicals. So all the supply of the tumor is well taken care of. On the other hand, if you use depth TACE, these particles do not get pushed beyond the sinusoids into the portal vein triads, and you do not achieve complete embolization of all the vascularity. So as radiologists, we always want to look at what we are treating. And now from these drug-eluting beads, there is a movement towards getting imageable beads, which we can see them on the ultrasound, on the X-rays, as well as on the CT. And that's the LUMI beads that have come up. And these allow us to combine these TACE with the ablations and TACE with the SBRT, because we can actually see where we are going to add the therapy. Moving now to the last part of my talk, that's the tear. We are all aware that we have microspheres which have the radiation and have no non-embolic therapy is delivered to the and there's minimal damage to the non-tumorous tissue indicated for bilobe disease and for PP3 and VP4 portal vein thrombosis. We have the glass or resin microspheres which give beta radiation, and we have the 25 micron size particles. So this is the difference between theta spheres and SIR spheres. Theta spheres have minimal embolic power. They are glass spheres, so they have less vascular stasis and reflux. There is inadequate coverage may occur with a larger lesion. On the other hand, for the SIR spheres, they have higher embolic power. The more resin spheres are used, and each sphere has lesser activity, so we achieve adequate and more homogeneous coverage of a large lesion. So this is a significant trial which looked at C-TACE versus tear, and though the time to progression was more with the tear, but the overall survival was reported to be almost similar for both conventional TACE and tear. So the Duseja trial, that's an important trial which looked at whether personalized dosimetry should be done or a standardized dosimetry should be done to achieve objective response. And in this study, it was found that the personalized dosimetry was significantly improved the objective response rate. So from a standard dose of about 120 grays, we've gone up to a delivery of a selective at least more than 200 grays, and some studies have even advocated delivery of 400 grays for the ablative segmentectomies. And subsequent to this trial, we have now the dosimetry calculators, which are available. These are the apps which are available online, which will help us, calculate how much dose we can deliver and how much to be delivered depending on the volume of the other factors, as well as the perfusion volumes and the volume of the tumor. As radiologists, as I said again, we want to see what we are doing, and now there is research going on these spheres which were earlier non-imageable on CT or X-rays. So now this is the I-90 microspheres which are evolving and under trial for this delivery of the Y90 therapy. So to summarize, RFA and microwave are comparable techniques for ablation of HCC. Microwave ablation is preferred for lesions larger than 3 centimeters, and for lesions close to blood vessels, achieves larger ablation and has less heat sink effect. IRE should be preferred for hepatic hilar lesions. Cryoablation should be preferred for hepatic lesions close to vital structures, excluding the hilar vessels. Catheter-based conventional techniques result in minimal toxicity and maximum response. CTACE is a widely available and inexpensive technique. We need to use tailored approach to local regional therapy of HCC based on expertise, cost, preference, and availability. And histotripsy is a novel ablation technique which is evolving and is under a lot of interest is now generating in it because it is an absolutely non-invasive and a mechanical cavitation technique. Radiopaque microspheres are being developed for both TACE and TARE, the Lumi beads and the I-90 respectively. Personalized dosimetry should be used for TARE. Multiple apps are now available free online for evaluating the dose that needs to be delivered to these tumors. Hybrid angio-CT provides useful information for intra-arterial drug delivery and if available should be used for these precision interventional oncology procedures. Thank you very much for your patient hearing. And I'd like to acknowledge my entire hepatobiliary intervention team, and all of them are here in the audience, and Dr. Prabjot, our DM student, who helped me with this presentation. Thank you very much.
Thank you, sir. Thank you so much for a nice presentation of ablation therapies. For microwave ablation, sir, the first question, what will be the upper limit of the size which you will prefer?
Well, if you look at the data, we usually do not, it's not recommended to go beyond 3 or even for microwave, but we have been treating tumors up to at least 5 centimeters in size using microwave ablation. So if you go by the recommendations, it's the same, don't cross 3 centimeters. But it works well even for lesions larger than that. In fact, we are at our institute, we are doing a study where we are looking at the role of microwave ablation for lesions for large size HCCs, and that large size is described as lesions between 3 to 6 centimeters in size. So based on that, we try to actually, there is, when we use microwave, there are different settings that we can do. The wattage settings as well as the time period settings. So there are some are described, regimens would be generated from these tables. So based on that, we can, see what area we can get at. You can do a second insertion as well and do repeat the microwave ablation. But I would recommend that if it is like somebody who's not routinely doing ablations, 3 centimeters should be the cutoff for them as well.
So if there are two solitary lesions separately in 2 segments and both require microwave, so is it preferable to do in a single sitting or?
No, there's no. You should go ahead with a single sitting. You can treat up to even 5 lesions in one go. There's nothing like that, and especially with microwave, the patient would be under conscious sedation only. So, and if you want to, if it is for patient comfort, you may, if you are doing, because these are short, mostly you can go from 2 minutes to 6 minutes. So they are short deliveries. So as I said, there's a procedural time for microwave is very short. So you can treat up to 5 lesions in one go. And if somehow you feel that your patient is not very cooperative and is fit for general anesthesia, you can use general anesthesia as well. Yeah. Otherwise, conscious sedation should work well for microwave ablation as well. Yes.
Sir, I have a question. I think, what is your opinion regarding the lesions more than 3 to 5 centimeter, and a combination therapy with an intent to treat in a single session, simultaneous TACE plus microwave for the lesions more than 3 to 5? Between 3 to 5.
Yeah, so the combination therapy is combining ablation with the endovascular therapy. So there is a lot of debate on that one. So the one debate is whether you should do the ablation first and follow it up with the endovascular therapy, because then the hypothesis here is if you do the ablation, there is surrounding hyperemia, and your whatever chemotherapy you will give will, because of the hyperemia, will enter that lesion. The other debate is whether you should do the endovascular treatment first and then follow it up with the ablation, which means if you are kind of devascularizing the tumor, so if you do the ablation after that, there is less heat sink effect, and then the effect is, that increases the effect. So this debate will always go on. And the second one is whether at all, there is data now for lesions 3 to 5 centimeters, 3 to 6 centimeters, you should do combination therapies combining ablation and endovascular treatment. Unfortunately, all this is retrospective data. So there are a lot of more than 100 studies on this, and they're usually most of these studies are from Southeast Asia, but most of this data is retrospective data, and that actually was this issue was raised in a Cochrane review where they actually questioned the validity of the data, and so you see that there is data, but all is retrospective, and unfortunately. None of this has found its way into the recommendations from any society so far. So, but yes, I am not saying that we should not do a combination therapy if we have lesions in 3 to 6 centimeters, but we should understand that the scientific evidence would be on the lower side to combine this therapy. Go ahead. So.
Excellent talk, Dr. Naveen. My question is there any cutoff of child status for doing microwave ablation? Can you do it in child C cirrhosis patients if there's a small tumor?
Well, that's an excellent question. So I would probably go ahead and do a microwave ablation in this setting, provided the size of the tumor fits into the criteria of a microwave ablation. And if that is the only lesion that the patient has, so there would not be any contraindication to do that. The only thing is that maybe we may prefer cryoablation because then in that case we don't even have to give any anesthesia. It's a local anesthesia, so we don't even have to give any kind of sedation in this patient. So that may be my preferred ablation modality.
And cryoablation, what is the size cutoff of the tumor?
Again, it is similar to the others. So, but the chamber size can be adjusted at the tip of the probe, and we can go usually go up to 4 centimeters. So that is if we have a tumor up to 4 centimeters, that can be well taken care of by cryoablation probe. Though you can introduce multiple probes and increase the size of your ablation, it can be easily done. But that is the recommended cutoffs for cryoablation as well, the 4 centimeter mark. I can repeat the question.
So with loco-regional therapy, we are pushing the boundaries now. Even when child C cirrhosis, you're able to do give curative treatment to these patients, and then maybe later transplantation.
Yeah, I think so. We can definitely do that. Yes, there is no contraindication as such to not doing it.
I would like to thank Professor Kalra and extreme gratitude from the Department of Hepatology, because you being as a backbone for all the kind of interventional therapies with your team is really commendable. Thank you, sir. And I thank for the INASL Clinics for this opportunity, and as well as you for giving this lucid presentation.
Thank you.
Thank you, sir.
Thank you very much. Thank you.
Now we close this session.
Thank you, Speaker and Chairpersons. So for the next session on surgical resection and liver transplantation for HCC, I would like to invite the chairpersons, Dr. Ashish Kumar, Professor, Department of Gastroenterology at Sir Ganga Ram Hospital, New Delhi, Dr. Divya, Professor, Department of Surgery at PGI, Dr. Saurabh Mishra, Consultant Hepatologist at Paras Healthcare, Panchkula.
Good evening, everyone. I'd like to invite Dr. Lileshwar Kaman, sir. He is Professor of Surgery at Department of General Surgery, PGI. Over to you, sir.
Thank you, Mr. Chairman, for your kind introductions. And ladies and gentlemen, good evening here. At the outset, I'd like to thank the organizing team of Department of Hepatology, especially Dr. Duseja in absentia and Dr. Sunil in presentia, definitely. Thank you so much. And today in the evening, I'll be speaking on the surgical management of HCC as a part of HCC clinic. As has been already discussed in many, the speakers, the previous speaker has discussed, that HCC is a very complex disease to treat, for that matter. And for surgical resections and liver transplantations, both are potentially curative, but they are still evolving, and different indications and other factors are taken into consideration so before we decide the modality of surgery. And as you can see from this pyramidal model, what are the things that we take into considerations as a surgeon? Number one is the presence or absence of cirrhosis and the liver functions. Number two is the availability of organ for liver transplantations, and ultimately the long-term outcomes in the form of recurrence. So what are the aspects I'll be touching in my presentation, sir? The prevalence of HCC in non-cirrhotic and cirrhotics, HCC dynamics, staging system for HCC, assessment of liver volume and liver functions, and differential clinical scenarios of HCCs, and of course the current status of outcome after resection and transplantations. Coming to the prevalence of HCCs, HCCs are present mostly in cirrhotic background up to the tune of 80 to 90%, and in non-cirrhotic, they can be present up to 20%. And about the HCC dynamic, the prognosis of HCC depends upon three factors after surgical treatment. They are mainly tumor biology and the tumor burden, underlying liver dysfunctions, and of course the general condition of the patient, that means the fitness for surgery and performance status. Coming to the HCC staging systems, already it has been discussed by Dr. Acharya. There are many staging and scoring systems are available, but the ideal system is not there yet. The most common staging system we as a surgeon we use are like HCC TNM staging, that is the American Joint Committee for Cancer staging system, where the tumor burden is only taken into considerations. Then we also use the Okuda staging and clip staging, where tumor burden along with the liver disease, underlying liver disease is also taken into considerations. But the most commonly and widely used staging system at present is the BCLC staging system, that is the Barcelona Clinic Liver or Cancer staging, that takes into account the tumor burden and underlying liver disease and the performance status of the patient. And it also gives the allocation to the treatment as well as the prognostications. And this is endorsed by both INASL and INASL, that is the American and European Society for Study of Liver Diseases. And in our institute also, personally, we follow BCLC staging system for management of HCC. So how do you decide between these two modalities of surgical treatment for treatment of HCC? Mainly, we look at the liver status, that is whether the patient is cirrhotic or non-cirrhotic. Definitely in non-cirrhotic, resection may be a better option, but if it is a cirrhotic patient, definitely liver transplant should be considered. And of course, the presence or absence of portal hypertension, that also decide our decision of surgical modality of treatment. And regarding technical considerations, size has been always an influencing factor for deciding the mode of surgery. But the site also is important in the sense, if it is a peripherally located tumor, like in segment 2 or 3, then you might get away with a kind of wedge resection, even in presence of cirrhosis. And one of the most important defining factor for our decision-making process is the FLR, that is a fusor liver remnant. And minimum of 30% FLR should be available in a non-cirrhotic patient after resection. But if it is a cirrhotic patient, 40 to 50% of FLR is required. And if the FLR is kind of, equivocal, then you can do the ICG, that is indocyanine green retention test, and it can give an idea about the functional FLR. And of course, advantage of resection is thereby you can avoid the lifelong immunosuppressants. And the advantage of liver transplant is that you can take care of the multiple occult lesions that may be present in a supposed to be single isolated lesion. Then assessment of liver volume, why it is important, why surgeons are so sensitive about the assessment of FLR. It is to prevent post-hepatectomy liver failure. The incidence is around 10%, and it is one of the most dreaded complications of hepatic resections, because it is, the mortality may be up to 60% if you cannot do a liver transplant. So it is a very unpleasant situation. We have burned our finger doing maybe, borderline, liver function with a, major resections. So both qualitative and quantitative estimation of the FLR should be done. The quantitative is mainly done by the radiologist, by the CT volumetric, but functional and qualitative estimation can be done with the ICG. And role of ICG in deciding the extent of liver resection is we follow the Makuchi's criteria. If the ICG retention test is less than 10% at 15 minutes, maybe you'll be able to, there is an indication of doing an extended dissection like a trisectomy. But if they say more than it is 40% at 15 minutes, then major resection should be avoided. Better you have to do a enucleation maybe. Then what are the clinical situations that HCC can present when we are sitting in our OPD or the hepatologist send the patient to us? There are main three clinical situations that patient can present to the surgeon. That is, number one is the HCC in non-cirrhotic patient. Number two is the HCC in cirrhosis, that is advanced cirrhosis, the child B or child C. And number three is the HCC in early cirrhosis, that is child A. So we'll discuss how do we manage in these three situations. So coming to HCC in non-cirrhotic patient, that is surgical resection is the choice of treatment. There is no doubt about that. Major and extended resections can be done depending upon your FLR. And the results has been excellent with good morbidity and mortality. And even the long-term result of overall survival and disease-free survival at 1, 3, and 5 years has been excellent. But the only problem with liver resections in HCC is that the recurrence, and that is the main cause of death. But the thing is that if there is a recurrence, if it is only intrahepatic, you may be able to do a repeat resections. Then what is the role of liver transplantation in non-cirrhotic patient? They have present with HCC. Early results were very poor. There was a systemic review from 1970 to 1990 that has shown 11% overall survival with a 40% recurrence for lesion that was 4 to 8 centimeter, and there was a 78% recurrence if the lesion was more than 8 centimeter at 1 year. So there was an international consensus conference that held in Zurich in 2010, and that conference recommended that the LT should be done in non-cirrhotic patient in non-resectable HCCs or those patients who has the intrahepatic recurrence after surgical resection, provided there is no macrovascular or extrahepatic spread. So what about the second scenario? The patient has come to you and presented with an HCC who has got an advanced cirrhosis like child B and child C. The in this situation, liver transplant is the only curative option. The liver transplant can cure the tumor as well as the underlying liver disease. and they should be within the Milan or UCSF criteria. But recently, lots of extended criteria has been proposed and implemented in selecting patient for liver transplantation for HCCs. Then the third scenario is HCC patient with early cirrhosis, like child's AA. It is a gray zone. All the controversies are here, how to decide about how to go about the surgical treatment in these situations. You have to remember, even though they have got a relatively well-preserved liver, the 1 year incidence of 1 year decompensation is around 7%. 1 year progression of the cirrhosis as well as the HCC is up to 12%. And 1 year liver-related mortality is up to 3%, which is quite high. And what are the treatment options in these situations? We have got a treatment options of doing a liver resection, liver transplantation, RFA and microwave, and all the local regional treatment like TACE, TARE, and chemotherapy. So how do you decide between resection and transplantation in these situations? It depends upon the tumor burden and tumor morphology, whether it is a unifocal or a multifocal, and location, as already I have mentioned, and presence and absence of portal hypertension, liver function status, future liver remnant, ICG status, and whether the patient fits into Milan, UCSF, or extended criteria. If you look at the INASL guideline for resection in early cirrhosis, they recommend that liver resection as the first-line treatment for HCC in early cirrhosis, provided they have got a solitary tumor and very well-preserved liver function test, and hepatic vein wedge pressure gradient should be less than 10 millimeter of mercury, and platelets should be more than 100,000, and FLR should be more than 50%. Then the key question is why liver transplant is the main option in HCC with cirrhosis. Liver transplant it is like killing two birds with one stone, and it treats the HCC as well as it replaces the underlying diseased liver with a new liver. And how do you do your patient selections? We usually kind of consider Milan and UCSF criteria. Both depends on the tumor morphology, and patient allocation is done by the MEL score, that is a MEL exception score. In Western countries, they give a 22 exception point, and with a 3 months increment of 10% up to the maximum of 36. And another question arises, why not transplant beyond Milan and UCSF criteria? The main thing is like the presence of MVI. If you look at the data, that if you transplant patient within Milan group, the microvascular invasion is around 11%. But if you go beyond Milan, the incidence of MVI will be more than 42%. And MVI, presence of MVI and the recurrence rate, they have got a direct proportionately that increases. So the recurrence of MVI patient who undergoes liver transplant is up to 70%. That is one of the limiting factors of not doing liver transplant beyond UCSF or Milan. So if you look at this table carefully, the risk of MVI and the size of tumor, you can see here if it is a solitary tumor, and if the size of the tumor is less than 2 centimeters, the incidence of MVI is 10%. And if the tumor sizes go beyond 8 centimeters, the MVI rate is 45%. And that multifocal tumor, it is double. So you can imagine the incidence of MVI and incidence of recurrence. This is one of the reasons why we should not be transplanting patients beyond Milan or beyond UCSF. But as I already has been discussed by Dr. Acharya lectures, nowadays people are moving away from morphological criteria, that was Milan and UCSF, to biological criteria, and it has opened up the potential to raise the bar for more transplantations. Addition of alpha-fetoprotein, tumor grade on FNAC, PET scan, and response to downstaging for HCC has been taken into consideration before deciding for a liver transplant. So this is all this, the proposals and all this criteria has led on to various extended criteria for HCC in liver transplant. Apart from Milan and UCSF, Pittsburgh criteria has been also proposed, then Hangzhou criteria, up to 7 criteria, that is proposed by the Milan group, that the Mejafuro group has proposed that it's up to 7 criteria. After the, I think, Metro Ticket 2 project, they have applied this into the liver transplant program. Here, 7 is total of size of the largest lesion in centimeter and number of lesion without any vascular invasion. The most radical extended criteria was from Toronto group. They doesn't have any upper limit on size and number of the lesion, provided there is no extrahepatic metastasis or evidence of venous or biliary thrombus or cancer-related symptom. So if you look at the extended criteria outcome, they were comparable to the benchmark of Milan and UCSF, but only thing was that they had the inferior survival, recurrence-free survival, that you have to understand. And if you're looking at the surgical outcome of intraoperative and postoperative and late postoperative, the surgical outcome is definitely, understandably better in liver resection in comparison to liver transplant. But if you look at the long-term outcome, that oncological outcome, and you look at the meta-analysis and systematic reviews, then I have taken only the recent 4 meta-analysis, and the inclusion criteria were HCC within Milan criteria or early cirrhosis. Overall survival at 5 years and disease-free survival at 3 years were better for liver transplant. And if you look at the LDLT versus DDLT for liver transplant in HCC, the liver transplant done for LDLT have got a impaired result. They have got a inferior result in comparison to DDLT in terms of recurrent-free survival at 1 year, 3 years, and 5 years, along with recurrence rate. Then coming to salvage liver transplant, the concept of salvage liver transplant is, upfront you have done a liver resection. If the patient recurs or the patient goes into post-hepatectomy liver failure, then you will transplant. The criteria used are tumor recurrence within Milan and UCSF. Early results were very poor, but current results are comparable, as you can see from this table. Then to summarize, what is the status of surgical treatment for HCC? It is in an algorithm form. HCC non-cirrhotic liver, if the FLR is more than 30%, you go for resections. If the FLR is less than 30%, you do augment the FLR by doing portal vein embolization. If it increases beyond 30%, do a resection. But if it does not increase beyond 30%, you do a liver transplant. And HCC in cirrhotic liver, if it is an advanced cirrhosis, if it is styles B or C, primary liver transplant is the treatment of choice. But if it is an early cirrhosis, like a child A, and there is no portal hypertension, and your FLR is more than 50%, do a resection, followed by maybe a salvage liver transplant if there is a recurrence. But if the FLR is less than 50%, then do a indocyanine and green test. Then if the ICC is less than 14%, and FLR is more than 40%, do a resection, and followed by maybe a salvage liver transplant if there is a recurrence. But if the ICC is 14 to 20%, you try to do a portal vein embolization, try to augment the FLR up to 50%. If it happens, do a reverse section. Otherwise, you go for liver transplantations. So, Mr. Chairman, coming to the conclusion, liver resection is the mainstay of HCC treatment for many conditions and many indications within the liver disease. And liver transplantation is emerging as a better option, definitely. Patient selection is of paramount importance, and consideration of oncological suitability, availability of organ for transplantation, and achieving a good long-term oncological outcome in patients with or without cirrhosis is the key. There is no one-size-fits-all approach in the management of HCC at present. Thank you.
Thank you, Dr. Kumar. It's an excellent lecture. So I would open up this for discussion. So I'll ask you first question. So if microvascular invasion is so important and because it predicts future recurrence. So if you see in your explant histopathology, there is microvascular invasion. So will your post-transplant surveillance change, that you'll do more frequent surveillance to pick up recurrences early, or will it remain the same?
Yeah, I think that is a excellent question in the sense. I think that will go very common sense definitely, because microvascular invasion is the determining factor for recurrence. One of the recurrence I have shown in one of the slide, like it can go up to 70% if it is present. Definitely, then it is a high risk group. So in the morning already, Dr. Chawla's, I think, and Dr. Singhal's lecture, it was decided like the specialized, special group will be, maybe they will be put on more, strict surveillance. Definitely, that is one of the, I think, good approach. Definitely, there is no doubt about that.
One question. Thank you, sir, for a very informative talk on surgical aspects of management of HCC. I am a bit confused and a small query regarding the role of liver transplant in non-cirrhotic HCC. You mentioned that it has shown that if you do transplant for non-cirrhotic HCC, the outcomes are poorer. At the same time, we know that the commonest cause of death with HCC is a recurrence of HCC in the tumor remaining liver. So are these two statements not contradictory, or did I miss something?
No, definitely. What I shown you that the systemic review was the liver transplant for a non-cirrhotic liver during the time of 1970s to 1990s. At that time, liver transplant was not so kind of advanced. The main flip came after, maybe the kind of implementation of living donor liver transplant. And after 90s only, there has been real improvement. What you can say is it has become the standard of care for CLD patient with HCC and other thing that you have to understand, number one. And second thing, you are talking about the contradictory thing like...
So what I said that if the commonest cause of death is a recurrence in the remaining liver, then doing a transplant would be the natural choice.
No, definitely, yeah. No, but the thing is that as I mentioned in one of the slide, but because of maybe time constraint, I did not put much of an emphasis. If you if you look at the data of histopathological analysis of the explanted liver after liver transplantation, there, the incidence of multiple HCCs were found to be more than 30%. Where you did a liver transplant, presuming that it was a solitary lesion within the Milan's criteria. So that also, influenced the final outcome. We must be doing those kind of, liver transplant for presume a solitary lesion and thinking that they will do well. But basically they had a multiple, tumors and maybe MVI. Microvascular invasion was already there. So there, these are fine things we cannot really pinpoint one particular thing for their outcome or their recurrences or their long survival. So those issues are there definitely.
Thank you, sir.
Sir, just 2 points, sir. First, with respect to the liver transplantation in HCC, if we see the Milan and UCSF at present, almost all living donor liver transplant centers in India, they are using the Toronto criteria. All patients who have intrahepatic HCC, even people have gone on further and they have transplanted VP1 and VP2 PVTTs also with excellent results. Yes, the recurrence rates are a bit higher, but if we don't transplant them anyways, they are going to die in next 12 months. So whenever HCC recurrence occurs, first most of them will occur extrahepatic, and once the liver is fine, we get so many options to treat them. If the tumor is in the bone, SBRT can be done. We have even seen patients who had recurrence in lung, lobectomy was done, and the patient went fine. So there is a case for doing liver transplants in patients who have only intrahepatic HCC. And the second point, sir, I would like to ask, if a patient has been started on an immune checkpoint inhibitors and now the patient is downstage and he becomes transplantable. So what is the washout period which one should take to transplant a patient, because we see there is increased incidence of rejection if the patient or patients who are once started on immune checkpoint, they are always out of transplant.
This is a complex issue. It is not only surgical or oncological. There are some kind of social issues are also involved. If you are talking about India and Southeast Asian countries, mainly the transplantation scenario is totally different from the Western countries. We do mainly here, I do not do personally, but in India we talk about, mainly it is LDLT program. And in the Western country, it is the disease donor, like the disease donor, liver transplantation program. LDLT hold the dynamics, whole, kind of mechanism that influence your transplant decisions is a bit different. LDLT, because the donor is, not a, kind of public property as it is in disease donor. So the people are transplanting maybe beyond Toronto group, extended criteria also. There actually how much we are really confining ourselves into the real kind of criteria for transplantation. It is a bit, difficult to understand. But I'm not blaming anyone for that matter. But what happens in that situation if you're transplanting beyond Milan's or beyond UCSF criteria? You may be transplanting more aggressive tumor because size also matter, because size is directly proportionate to be maybe to the tumor biology. So you may be transplanting more aggressive tumor. That is number one. And second thing is you may be transplanting too early after the diagnosis of HCC. The standard is what? That the consensus, the report in Zurich, they have, recommended that minimum 3 months of waiting period before going for a living donor liver transplantation. But here in this situation, what happened? You are also under pressure of the patient relative and patient, they say like, we don't want to wait for 3 months. So you are maybe transplanting too early. In fact, I showed you the kind of meta-analysis between LDLT and DDLT. The results of LDLT were impaired. They were inferior to DDLT. But the exact cause was not, we cannot pinpoint the exact cause, but these are the things that was given in explanation. So we keep telling that maybe we are transplanting beyond this criteria, standard criteria, number one. Second thing is we are transplanting more aggressive tumor biology. And maybe we are transplanting too early because we are not allowing the tumor to express its maybe natural history. If you wait for 3 months, if it is an aggressive tumor, anyway there will be metastasis, macrovascular infiltration and other thing will happen that you will exclude the patient natural selection. But if you are transplanting too early, you don't know. Then the patient will recur within maybe 3 months, 6 months, and ultimately your whole transplant process is in futile. But always the patient can say, this is my own thing, my expenses are mine, donor is mine. So what is your problem?
With this, I think we'll conclude this session. Thank you for
Thank
this
you, sir.
excellent lecture.
Thank you, sir.
Thank you, Speaker and Chairpersons. So we come to the last session of the evening on panel discussion, real-life management of HCC in India. I would now like to invite the chairpersons, Dr. Umesh Goel, Professor, Gastroenterology at DMC Ludhiana, Dr. Sahaj Rathi, Assistant Professor, Department of Hepatology, PGI, Dr. Nipun Verma, Associate Professor, Department of Hepatology, PGI, Dr. Divya Khosla, Associate Professor, Department of Radiodiagnosis and Medical Oncology, PGI, Dr. Harish, Assistant Professor, Department of Radiodiagnosis, PGI, and Dr. Ajay Salwania, Assistant Professor and Liver Transplant Surgeon, PGI.
So, good evening, everyone. I think we are running late, and my job here is to summarize what has been discussed since evening. So, I'm going to present a real-life case scenario, and we have an esteemed panel with us. We have a gastroenterologist, 2 hepatologists, intervention radiologist, oncologist, and a liver transplant surgeon. So, let me just quickly take you through the case, and We'll quickly try to wind up in 30 minutes time, which has been allotted to us. Okay, so he is Mr. RK, a 58-year-old male, diabetic, hypertensive, and he was a chronic alcoholic in serogenic doses, and presented with history of weight loss and loss of appetite for 3 months. On examination, he was obese, and his liver was palpable 3 centimeters below costal margin. Rest of the examination was essentially normal. Let's look at his investigations. INR was normal, platelets were preserved, creat was normal, bilirubin was marginally elevated 2.1, and the albumin was on the lower side. He was worked up for the etiology of liver disease, and all the workup was negative. Endoscopy revealed grade 2 esophageal varices, and the fibroscan showed an LSM value of 29 with cap of 289. He underwent an ultrasound which showed liver parenchymal disease with ill-defined hypoechoic lesion in the right lobe, and this was followed by a CT which showed a large hypodense lesion with intense arterial enhancement in the arterial phase and washout in the portal venous phase. And the size of the tumor was 9.3 into 9 centimeters with right portal vein thrombosis. There was no evidence of ascites. And these are the CT images, large lesion in the right lobe, and there was right portal vein thrombosis. The alpha fetoprotein came out to be 1125, and the PIVCA was also elevated. He also underwent FTG PET, and again that confirmed that there was a large HCC and there was no evidence of extrahepatic metastasis. So we've already discussed the diagnosis of HCC. I'm not going to go into the details now. This is the EASL definition, which says that radiology is good enough. And when we talk about ASLD, this is the LIRAIDS classification, LIRAIDS 1 to LIRAIDS 5, and LIRAIDS 5 is definitive HCC. And if you look at the updated BCLC classification, which is used for management of HCC, he would fit into advanced stage HCC. And the final diagnosis of this patient was alcohol plus metabolic syndrome cirrhosis with HCC, single lesion right lobe, and he would fit into BCLCC with elevated alpha fetoprotein and PIVCA. So let's move on. And first question, I think I would address to Dr. Nipun. Do you think there is any role of liver biopsy? We've been talking about it since evening.
So, liver biopsy is generally done in patients with HCC where the diagnosis itself is in doubt. Whereas in this case, the radiology is very typical and the alpha fetoprotein, which also signifies. And as per the guidelines, it is recommended only on the case-to-case basis. They also recommend that biopsies should be done in patients for characterization of molecular signatures and inflammatory signatures and to predict the immune checkpoint inhibitor related therapy response, but this is not recommended as an upfront modality for doing the assessing the response. So it is decided on case to case basis, and mainly it's a research tool for precision medicine and the AI based therapies which is developing in the future. So presently it is in the research domain.
So I think the message here is clear that you don't need biopsy right now upfront for making the diagnosis of HCC. Imaging is good enough, and if you have any doubt in the diagnosis, then you should do a biopsy. So this is the ASLD recent guidelines. It's not routinely recommended, and if there's any doubt, then you should do a biopsy. So let's move on quickly. Management of HCC. This has already been discussed. You have surgical management, you have local regional therapy, and then you have systemic therapy, and the last is SBRT. So let's go to the next question. Dr. Umesh, he's a gastroenterologist. So if such a patient comes to you, what is your one-stop shop for this patient? Whom would you consult, and how would you decide about the treatment in such a patient?
So as already discussed, I mean, HCC management is always a multimodality treatment, and ideally we should have a tumor board. There's no one-stop person who can and who should decide the therapy. But obviously, patient comes to us, a gastroenterologist, a hepatologist, so we have to stage the patient. So this patient falls into BCLC C, and according to the INASL, it is C1 because it doesn't have metastasis. It's a portal vein thrombus. So for BCLC C therapy, as per the for the BCLC C, I mean systemic therapy. Conventionally, we used to say this, but now as we have more and more literature and the INASL guidelines, we now know that we have
some more therapies to offer besides the systemic therapy. So we have SBR. Yeah.
If you look at the BCLC staging, so recommended treatment in BCLC
Is systemic
is
treatment.
systemic therapy. So would you give him systemic therapy at this stage, or you would
Yes.
think about something else?
Systemic as a yes, because this is C1 according to the INASL guidelines. So we have other therapies to offer like SBRT. We can even go for ablation and even resection if possible. Has been reported to have done in such cases.
So I think the message here is guidelines are for guidance, and in this case, for advanced HCC, systemic therapy is recommended. And this data has already been shown that you can use various drugs, and first-line treatment is Atezo-Bev, and this was the landmark trial which was discussed earlier also. So let me skip this. Improved survival with this therapy, disease-free progression is less, and better quality of life with this combination. So let's go to the different other perspective in this case. So Dr. Sej, do you think that we would give systemic therapy, or you think that you have other modalities which can be used in such a patient?
So if we go by the guidelines and the evidence strictly, the systemic therapy, especially with Atezo-Bev, as you said, would be the ideal thing. I mean, not ideal, but what would be recommended. However, given the fact that this is likely a branch portal vein thrombus, and this is a case where tear, ablative local regional therapy in the form of tear might actually be helpful. Also SBRT, a radiation therapy, SBRT also there's upcoming data on larger tumors being treated downstage with SBRT. Now we have data on that. So I think that again, it should go to a multidisciplinary tumor board, and the options discussed with the patient. Patient should be a part of this discussion, because the cost of systemic therapy with Atezo-Bev in long term is going to be very prohibitive, and we are a cost sensitive nation. So that the option of systemic therapy as well as local regional therapy in the form of TARE / SBRT should be explored here.
So if this patient is in your OPD, what would be your treatment of choice for such a patient?
So as I said, there cannot be one single treatment of choice in a patient who comes like this. We have to take into account a lot of things: the functional status of the patient, the expenses that the patient has to incur, the choices of the patient, and then only we can proceed. And it should not be one person who should be taking this decision, that's for sure.
So I think the message again here is clear. You need a multidisciplinary team for management of such patients, especially when you have large tumors, vascular invasion. So let's look at the INASL guidelines. What does that suggest? If you have advanced HCC and if you have vascular invasion, the therapy which has been recommended is SBRT, even resection, there's data on that, and TARE. So if they do not qualify for this therapy, then they should go on to the systemic therapy. So I think though the BCLC guidelines recommend that systemic therapy should be the first line, the INASL guidelines have deviated a little bit, and they have suggested that TARE can be used, and even SBRT and resection can be tried in a special subgroup of patients. So I'm not going into the details of all this, but let's just move forward. And these are the liver-directed therapies which are available. This has already been shown by Dr. Naveen Kalra. So let's go to Dr. Harish. Okay, if you have such a patient and you have to offer loco-regional therapy to such a patient, what kind of loco-regional therapy will you decide, and how do you decide for loco-regional therapy in such a patient in a real-life situation?
So when this case comes to in intervention radiology, so first thing is the size of the lesion is of course a large size HCC, and there is associated portal vein thrombosis. So if there is a lesion with segmental or the subsegmental thrombosis, then we can go ahead with the TACE or conventional TACE or the DEP TACE. But in this case, I think right branch is having thrombus and the lesion size is larger, so we should go ahead with the TARE, that is Y90 TARE. But of course it's depend upon the also finances of the patient, because Y90 TARE cost more than the other therapies. So for TARE is thrombosis depending upon thrombosis, so right side thrombus, so we should go ahead with the TARE in this particular in this case.
So any role of DEP TACE in such a patient, because there's just a branch chain thrombosis?
So
main portal vein thrombosis, I would agree, let's do tear. So in branched chain thrombosis, do you think that
So if
TACE
there is
can help?
if there is a segmental thrombosis, even if patient is having the unilateral either right or left, it depends upon the remnant liver. If the left lobe is very good, then we can think of it because it can cause the post-embolization syndrome, and patient may end up in liver failure after the TACE because it causes the embolization. And if the thrombus is extending into the main portal vein, then there is no use of TACE, or TACE is rather the relative contraindication.
So Dr. Naveen, you are here. Any different thoughts that TACE versus tear in such a patient who has a branched portal vein thrombosis?
I think Harish has addressed this very rightly. So I agree with it. So this particular case, with such a large tumor, we would definitely prefer doing tear. It's almost touching 10 centimeters. So beyond 10 would be a contraindication for TACE actually. And plus the patient also has portal vein thrombosis. So I agree with what Dr. Harish has said.
So large
tear would
tumor,
be the
just based on the large tumor of the size and the presence of portal vein thrombosis, you think that tear would be shade better as compared
yes,
to
the PES, the post-embolization syndrome is going to be very minimal if we resort to tear. And then yes, in our setting, clinical setting, costs are a big factor. So that will have to be taken into consideration. If at all we are not doing tear, we'll have to do a multi-session TACE rather than trying to take care of the entire lesion in one go. So I agree with what Dr. Harish is saying.
Sir, if the cost is not a consideration, what would be the first choice?
Tear.
What should
Then
be the first choice?
tear.
So tear.
Why
So
not? It's a guidelines suggest this immunotherapy.
yes, guidelines would say that you should give immunotherapy in all such patients. Tear is obviously the modality of choice here, as Dr. Naveen has suggested, and various radioactive materials are available. Most commonly, which is used is yttrium. And the only contraindication for tear is, I would say, decompensated liver disease. And if you have a high lung shunt fraction, or there is a massive infiltration of the liver, and there is severe renal, cardiovascular, or lung comorbidities. And it has shown that tear has definitely good role in large tumors because the post-embolization syndrome is less. And the only issue is in our setting is the cost which is involved in doing a Y90 tear. So otherwise, in studies, it has been shown that for larger tumors also, the efficacy might be almost similar when you do TACE versus tear. The caveat being that in TACE, you have more of post-embolization syndrome and the risk of ischemia is there. So let's just go forward. And this was the premier trial. This is for small tumors where they've shown that tear fares slightly better as compared to TACE, and time to progression is less with yttrium tear as compared to TACE. But for larger tumors, I think the data is still not there. So let's go on to Dr. Divya, and you have such a large tumor. If the patient is not a candidate for loco-regional therapy, would you offer SBRT to such a patient?
Size is considerably large, and SBRT is limited mainly by its ability to meet the dose constraints. And we have to see in such situations what is the volume of the uninvolved normal liver parenchyma. And if we are able to meet, there are two requirements. One is the mean dose to the uninvolved liver, and rest is the volume constraints, which we see that the 700 cc of liver. So depending if we are able to achieve that, we can consider for SBRT, and we're going to fractionate it more, maybe 5 to 6 fractions. And the dose would be 40 grain, 5 to 6 fractions.
So do you think he's an ideal candidate for SBRT?
Not an ideal candidate.
Yeah, so most of the times it's been done for smaller tumors.
Not exactly for smaller tumors what we get. We usually get tumors which are large and with vascular invasion, and those who have failed on the other loco-regional therapies, or they are deemed unsuitable for other loco-regional therapies, or elderly group.
Okay. So do you think that the results are better with single session, or it's like a staged kind of therapy? How do you do that?
SBRT is typically given in 3 to 5 or 6 fractions, and the dose depends upon the underlying liver function, extent of the lesion, which basically includes both the size of the lesion as well as the number of lesions and the underlying liver function. So this is not an ideal case for SBRT. The first thing that we would do a triphasic scan, and if we are able to meet the dose constraints, we'll go ahead with the SBRT. And the prescription dose and the target coverage they can be adjusted to meet the dose constraints. And with SBRT, there is nothing like all or none phenomenon, which we usually see with other local
Any strict contraindications where you will not do SBRT?
decompensated, basically ascites. We don't.
Ascites. So you
Yes.
don't do it if there's presence of ascites. So any decompensated disease, you will not offer SBRT. But in such a case, patient, if he's not eligible for local regional therapy or systemic therapy is not affording, then SBRT can be offered because it's a cheap alternative. And I'm going to skip this in the interest of time. And
Alternative in government setup, not in the private setup.
yeah, that's true. Yeah.
In PGI, it costs about 10,000, but in private centers, depends upon the number of fractions. So it basically costs around 2.5 to 3 lakhs.
So this is the data, and it's been seen that it has pretty good outcome if you use SBRT in patients with HCC also. And let's go to the surgeon now. So any role of resection in such a patient? He has a large tumor with a segmental portal vein thrombosis. Would you consider surgery at any stage in this patient?
Not in this patient. The reason being very large tumor, almost 10 centimeter, and there are three poor prognostic factors which I can make out, and that one is alpha fetoprotein, second is large vessel involvement, and third in PET also the SUV looks quite high actually. And the pertinent point is the FLR looks less actually, although it needs to be higher. So that way it is not. But there is a data for large tumor where vessel is not involved. The surgical result of resection is better than TACE and tear also. So that way.
So which group of patients will you consider surgery?
Child A, early child B.
Yeah, he would fit into that.
And with 10 centimeter also, we can consider resection if performance status is good.
He has a good performance status.
Yeah, not here. FLR doesn't look adequate because.
So one is FLR, but look at his platelet count; it is preserved.
Yeah, that way it looks good, but still, if his residual liver won't be good, so he's not doesn't look a good candidate.
So I think the message here is that you have to carefully select patients if you are considering surgery, and if the residual liver volume is not good, then surgery is out of question. But let me just show you some controversial data which is just been published, and this is surgical resection for HCC, and this is beyond BCLC systematic review, and they've posed management algorithm also, included 20 studies of resection, 4,000 patients, and average the tumor size was 12.3 centimeters. Cirrhosis ranged from 5 to 83%, and overall survival ranged from 16 to 60% with a mean survival of 33.5%. And this is what they have suggested, that surgical resection is feasible. You have to assess for risk factors. If it is more than 10 centimeters, if the AFP is highly elevated, if there is any evidence of microvascular or capsule invasion or macrovascular invasion, you have to be careful. But in selectively chosen patients, surgery can be offered in larger tumors, and they've shown this comparison with TACE. The survival seems to be shade better as compared to TACE only. So the message again I would say is that can be done in a select group of patients only. So let's see that, is there any role of downstaging in this patient, Dr. Nipun? Would you like to downstage this patient and consider for transplant, or transplant is out of question in such a patient?
Let's say if we are following the guidelines, then according to the guidelines, it's out of guidelines. Basically, guidelines say, ASLD recent guidelines say, UNOS downstaging criteria, which says that single lesion less than 8 centimeter or more than 2 to 3 lesions less than 5 centimeter, or 3 to 4 lesions, each lesion less than 3 centimeter. So it's clearly the lesion is more than 10 centimeter. And in the guidelines, the criteria is there should not be any vascular invasion or extrahepatic spread. So in this patient, there is a vascular invasion. Having said that, apart from the guidelines, let's say if we can do certain therapies like TARE and do SBRT for the portal vein thrombosis and downstage this tumor to within Milan or UCSF and do the transplant. And what are the chances like? So the chances like is near about 60%, as the Medanta group are doing such kind of therapies. And if we see the 5 years overall survival in such group of individuals, then it's near about 55%. And if we don't do, the survival is close to 5 or 10%. So yes, if possible, downstaging and followed by transplant. That should be the intent for a given individual after discussion with the patient.
Dr. Ajay, your thoughts on this?
Yeah, the data, there is a recent commentary published by Dr. Soin and group in the Journal of Hepatology. What they say is like generally the tumor, what they've operated was not of this big size actually. And the tumor into the vessels has gone into segmental and sectoral portion only they have considered primarily. Only few cases in their cohort was the people where the tumor has gone into the right main portal vein. So I will be like considering performance status and the financial constraint, everything, and the longevity of the life. It will be kind of again the tumor board will decide. So that way it will be good. So I will be hesitant to perform a transplant for this patient considering longevity of the life.
So if you look at this alpha fetoprotein of this patient, it's more than 1,000.
Yeah.
Dr. Sage, upfront, do you consider transplant after downstaging, or you will say no to transplant in this patient?
So with a alpha fetoprotein of more than 1,000, there is a very high risk of extrahepatic mets as well. And obviously,
the PET did not show mets.
The PET did not show. There might be micromets. So I would like to give this patient some time. I would like to evaluate this patient. There might be mets cropping up. At the same time, this is not an ideal candidate for transplant anyways. So what I would want to do is go for a locoregional therapy. A possibility, as Dr. Ajay pointed out, that there's not enough FLR. A possibility that can be considered after discussion with our radiology colleagues is a radiation lobectomy. We can go for a whole, right lobe radiation lobectomy that will take care of the locoregional therapy part, as well as give time for the left lobe to grow, maybe achieve tumor, the real tumor control, as well as give a reasonable functional liver residue for surgeons in the future. So that would be how I could possibly approach. At the same time, it will also give us a chance to look at the dynamic AFP. If the AFP comes down to less than 200, that would be a good case, because we have had some data lately in the last 2-3 years that a dynamic evaluation of AFP for locoregional, although that has not included vascular invasion, if I'm not mistaken, but a corollary can be drawn that if the AFP is dropping down to less than 200, then maybe a case can be made for transplant later.
Dr. Mesh, you have very aggressive transplant surgeons in India. They are doing LDLT, and some of the centers, they say that if the tumor is in the liver, we would transplant. So what is your thought on that?
I mean, this case is slightly not a good case for liver transplant because of the high AFP levels, and as discussed that we could be having micrometastasis.
So the patient comes with a relative that he's willing to donate, and finances is not an issue.
Yeah.
And we are happy with 1 year survival also, and we have a donor with us.
Then we have
what would you recommend to such a patient?
We have to first obviously downstage this, and then
this is a real life scenario, because some patient would come to you, okay, we are happy with transplant, whatever you do. We want a transplant from a patient. I have a donor.
Yeah.
Would you suggest, or would you say no straight away?
Then we have to explain them the chances of recurrence. I mean, in this case, it would be high chances. So if the family is willing with that, I mean, they have to weigh the benefit and risk of getting that. I mean, if the survival after transplant, the recurrence is so high, then we have to clearly explain them that they might be futile. All the efforts risking the donor and spending so much of money would be futile if the chances of recurrence are so high.
So I think sir, please. Sir, in a LDLT setting, there is a situation where the patient comes with a donor and he says, I am happy with 1 year survival, you transplant.
But then otherwise the whole kind of about ethics and the criteria and the recommendations and the guidelines, then that should not be existing.
Sir, if you look at the criteria which are used for transplant, they've gone beyond all criteria.
Yeah.
There is, the metro ticket concept or the other Kyoto criteria or Toronto criteria, whatever. So people have transplanted for large tumors. My question is that would you transplant or give an option to this patient, or it's no at all for transplant?
At some point of time, you have to say no. Patient and then will be always insisting. But the thing is that, we are the counselor and we are the knowledgeable person who can give them the proper guidance. Is not it? If we know that this patient is a very high risk patient, number one. Second thing, high risk of recurrences. And third thing is not doing well is also very high risk. Immediate post-operative, outcome may not be very good. Knowing everything, just because the patient has got a donor, just because it is feasible, that we should transplant?
Sir,
That is my question.
Yes, sir. Your thoughts on downstaging and then transplanting such a patient?
Yeah, maybe. That may be considered, definitely. I will agree on that thing. But upfront transplant, I will never advise that.
So upfront, no transplant for such a patient, and message here is clear. In such patients who have large tumors with vascular involvement, transplant should not be offered. Downstaging can be done in such patients. Try and bring down the tumor within criteria, whether it's UCSF or Milan criteria. The alpha-fetoprotein or other biomarkers have to come down. You have to give a period where you have to watch such patients that they do not have recurrence, and then think of transplant. So no transplant upfront. So let me just tell you briefly what we have done for this patient. I'm going to skip all this slide because of the constraint of time. There is some data from this Delhi Institute Medanta that they've done for portal vein thrombosis, segmental portal vein thrombosis, but this is again after downstaging. So I'm going to skip this, and they have shown some good survival, up to 50% 5-year survival in patients with portal vein thrombosis. Okay, so in this index case, we decided to go ahead with TARE, and this patient underwent TARE. There was a good uptake and there was a good improvement after doing TARE, but subsequent to this patient had extrahepatic mets after 3 months. And this patient has received six cycles of immunotherapy after that. So he was doing well, but then he succumbed finally to a cardiac event. So in this patient, we had done TARE followed by immunotherapy, and he had a good survival after that. So message here is that you have to individualize the management of HCC, and it has to be a multidisciplinary approach. You can't just have one-stop shop for such patients. Clinical decision making is very important. So patients will come to you and they would say that, okay, I have read Google and it says that transplant is feasible in all patients. Systemic therapy can be given in all patients. Please do TARE, TACE, whatever. But then the decision has to be taken by a multidisciplinary team. You have to suggest the best treatment which can offer survival benefit, not just for the sake of doing treatment. So if proper selection of candidates is done, safe and effective treatment can be given and survival can be improved. So I'm going to stop here, and thank you very much for your patient listening. I want to thank all the panelists for their inputs. Thank you very much. So Dr. Ashish, would you give the vote of thanks?
So with this, we come to the end of our session, the second INASL HCC Clinics, and I'll be proposing vote of thanks. So first of all, I would like to thank all the delegates who have come and sat through all the sessions, and we have crossed the time limit. We are more than 1 hour late, but still all of you are sitting. Thank you all. I would like to thank all the speakers who have made their good presentations and generated lively discussion. I would also especially thank Dr. Amit Singhal, who came all the way from US to give his presentation. I would like to thank all the chairpersons and moderators for making these sessions very lively. I would like to thank Roche for their educational grant for conducting all these 6 sessions. The educational grant given to INASL, which has given the platform for this all these 6 sessions. And last but not least, I would like to thank the event management company TMAC Corporation and Navjot and her team for this flawless event management and this audio visual. So thank you all, and I would like to invite you for the next session, that is at Bangalore on 15th of July. And if you are able to attend physically, that is also good. Otherwise, it will be available on the YouTube live discussion. So thank you, and I invite you for the dinner. Thank you.